the WHO group itself, but it was not officially WHO at that time, and therefore now stands for not officially WHO. The goal of this consortium was basically to review the literature for new molecular markers, new biomarkers, new molecular alterations, and which have some clinical significance, and to decide which of these molecular markers can be incorporated into the subsequent classifications. There are 7 updates of the C-impact now that have been published between the years 2018 and 2020, and all of them are published in Acta Neuropathologica, which is the official journal of the International Society of Neuropathology, and those of you who are interested can go through these updates. And it is the recommendations of all these updates that are now incorporated into the current classification that we are all following, that is the WHO 2021 classification. This is the 5th edition, and very popularly referred to as the WHO CNS5. And therefore, this classification advances the role of molecular diagnostics even further in CNS tumor classification. Nevertheless, it is deeply rooted to established approaches of tumor characterization. So what are those established approaches? It is histology and immunohistochemistry. So we still have histology and immunohistochemistry, which plays a very important role in the classification even in this 5th edition, and therefore the classification presents a hybrid taxonomy to us. So let us look at some of the major changes that have happened in this WHO-CNS5. So some of the major changes include revision in CNS tumor taxonomy, CNS tumor nomenclature. We'll discuss each one of these. There is revision in the CNS tumor grading and introduction of new tumor types and subtypes. Every time a new classification comes out, there will be some new tumor types and subtypes that gets introduced. And there is the use of the 2 terminologies, not otherwise specified, NOS, and not elsewhere classified, that is NEC. And the use of a very new high-throughput molecular technique known as DNA methylation profiling that is used for the diagnosis of some of the tumors, and the use of what is known as layered reporting or the integrated diagnosis format. So all these are the major changes that have happened. Let us look at each one of them very briefly. First is the revision in CNS tumor taxonomy. Now, the reason this classification is hybrid is because some of the tumors are diagnosed based on their underlying genetic alterations, that is, they're genetically defined tumor types. For example, astrocytoma IDH mutant, diffuse midline glioma X3K27M mutant, or astroblastoma MN1 altered. All these are defined by the genetic alterations. So you cannot make a diagnosis of these tumor types without demonstrating these genetic alterations. But there are some tumors where we can diagnose them only based on histopathological features like meningiomas or pilocytic astrocytomas or ganglioglioma. Sure enough, they do have genetic alterations, but that is not required for the diagnosis of these tumor types. And there are some tumor types that can be diagnosed based on both histological features and molecular features. For example, medulloblastoma. We have 2 groups in medulloblastoma: a histologically defined group, which has all these tumor subgroups such as classic, the desmoplastic nodular, the large cell anaplastic, and we have this molecularly defined medulloblastoma, which has the subtypes such as the Wnt activated, SHH activated, and others. So these are diagnosed based both on histological as well as the molecular parameters, and that is the reason this classification is a hybrid classification. And in order to standardize this WHO-CNS5 with the other 5th edition blue books, some terminologies have been changed. For example, we don't use the term entity anymore. In the earlier classifications, they were all referred to as tumor entities, but now we call them as tumor types. And histological variance is now designated as subtype. So we have only type and subtype. We do not have any tumor entities and tumor variants, and it's the types that are listed in the classification. Now there is revision in the CNS tumor nomenclature based on certain modifying factors. If you look at anatomic site modifiers, for example, there is this tumor called chordoid glioma. In the earlier classification, this was chordoid glioma of the 3rd ventricle. But the term 3rd ventricle is now deleted because now we know that chordoid gliomas can occur anywhere else also in the brain, not just in the 3rd ventricle. And there are some nomenclatures have altered based on genetic modifiers. For example, glioblastoma. Now earlier we had glioblastoma IDH wild type and we had the glioblastoma IDH mutant. But IDH wild type is retained whereas the mutant is removed. Supratentorial ependymoma relofusion positive is retained. Now it is known as effusion positive because there is a change in the name for the genetic alteration. And there is this embryonal tumor known as ETMR. It is embryonal tumor with multi-layered rosets. It is characterized by a particular genetic alteration known as C19MC alteration. So in the earlier classification, this tumor was designated as ETMR C19MC altered. But now the C19MC alteration is removed because now we know that ETMRs can have other mutations also, like dicer1 alterations. Other mutations are known in ETMR. So we call it just ETMR. So there are changes in this or revisions in the CNS tumor nomenclature. And WHO-CNS5, it pays a lot of importance to gene and protein nomenclature and uses this Hugo Gene Nomenclature Committee and Human Genome Variation Society recommendations for gene symbols, names, and sequence variants. You should remember this. Gene symbols are all presented in italics, but the proteins in the gene groups are not italicized. And we prefix this letter C for any gene sequence alteration and the letter P for protein sequence. Let us look at one example. The most common genetic alteration in adult diffuse gliomas is IDH1R132H mutation. What is the gene sequence alteration? Gene sequence alteration here is IDH1C.395G2A. That means there is a transition from G to A in nucleotide position 395, and that results in this protein sequence where you have IDH1P.R132H, where arginine is replaced by histidine in position 132 of the amino acid sequence. Now, there is revision in CNS tumor grading in this WHO-CNS5, and we now use Arabic numerals for grading and not Roman numerals. The reason Arabic numerals are used like this is because it has to be made uniform with other WHO grading systems. In all other WHO grading systems, it's Arabic numerals. So even in CNS, it has become Arabic. And moreover, the Roman numerals used to give rise to some transcription errors. For example, for 1 could be typed as 2 or 2 as 3, some sort of transcription errors. And the term CNS WHO grade is introduced for every tumor type. So if you want to grade it, you have to use the CNS WHO grade. So for example, ependymoma. Ependymoma is a CNS WHO grade 2 tumor. So like that, you have to use this terminology known as CNS WHO grade. And there is grading within the tumor types. For example, astrocytoma IDH mutant is graded as CNS WHO grade 2, grade 3, grade 4, and that replaces the previous terminologies. Diffuse astrocytoma was what we used to, what was designated for this grade 2 tumor, anaplastic for grade 3, and IDH mutant glioblastoma for grade 4. So we don't use these terminologies anymore. And the term anaplastic is eliminated for grade 3 tumors. For example, pleomorphic xanthoastrocytoma, it has 2 grades, grade 2 and grade 3. Grade 3 used to be designated as anaplastic PXA earlier, but now we don't call it anaplastic PXA. You just call it PXA CNS WHO grade 3. A combined histological and molecular grading is applied to some tumor types. For example, astrocytoma IDH mutant. We'll come to these tumors. Now, we know that we can grade these tumors based on histological parameters, and we look at some of those histological parameters. But now we have one molecular parameter also that is included for grading, that is CDKN2AB homozygous deletion, and we look at this a little more in detail subsequently. Glioblastoma IDH wild type. For grading, we know the histological parameters, but apart from histological parameters, there are these molecular parameters such as EGFR amplification, TERT promoter mutation, gain of chromosome 7, loss of chromosome 10, copy number changes that will be used along with histological parameters for this glioblastoma IDH wild type. And WHO does not assign grades if it confuses clinical care. For example, diffuse leptomeningeal glioneuronal tumor and astroblastoma glioblastoma, MN1 order. They are not assigned any grade by WHO because even now, till now, we do not know exactly how these tumors behave, whether there are subsets of the tumors that behave in a better manner, subsets that do not behave in a better manner. Therefore, the grade is not assigned to these tumors. So as I told you, in every classification, there are new tumor types and subtypes will be introduced. And in this classification, we have 22 newly recognized tumor types. 14 of them come under the group of gliomas and glioneuronal tumors, and 8 under the other groups. And let me tell you that the majority of the newly recognized tumor types are all in the pediatric age group, as you can see in these boxes. Now, we also use this terminology NOS and NEC, which is allowed by WHO. So what is NOS? NOS is not otherwise specified, which implies that the necessary diagnostic molecular tests, they were not available, they're not performed, or the results are inconclusive. That is, you're in a center where you couldn't do these molecular tests, and so you can use this terminology NOS, and that's only a red flag. It will prompt additional testing, that this case has to be tested for a particular molecular alteration in another center. NEC is not elsewhere classified, where you did all the necessary molecular tests, but the results, they do not allow for a proper WHO diagnosis. That is, there is some kind of a histologic or genetic mismatch. In both these situations, one can consider what is known as a layered reporting format. This is very interesting. Have a look at the layered reporting format. A layered reporting format is one that optimally combines morphologic and molecular data to generate a layered neuropathological diagnosis. And this is the example of the template for a layered diagnosis that is put forth by WHO itself, which has 4 layers, as you can see here. The first layer is the integrated diagnosis. This is typically a WHO diagnosis. It has whether it is genetically defined, histologically defined, it should be a WHO diagnosis. If you cannot reach this diagnosis, then you call it as NOS or NEC. And if you, the second layer is histopathological classification that is based on histology, immunohistochemistry. Mind you that this can be different from the integrated diagnosis. That is, for example, you have a tumor in a pediatric age group where the histopathology looks like oligodendroglioma, but the molecular alterations are totally different. It is not at all an oligodendroglioma. It could be a MAP kinase altered pediatric type of low-grade glioma. So this is a histopathological classification. And CNS-WHO grade is an integrated CNS-WHO grade. That is, you should have this integrated WHO diagnosis to call it CNS-WHO grade. If you have an NOS diagnosis, then you cannot call it CNS-WHO grade. You have to say histological grade. And the last layer is molecular information, where all the molecular findings are listed along with the genetic platform that you use for the molecular testing, like whether you use immunohistochemistry for the surrogate markers, genetic assays like FISH or the Sanger sequencing, next-gen sequencing, methylome profiling, whichever assay you use, you can list it as that assay. Let us look at 2 examples. This is the first example. This is the integrated diagnosis is a complete WHO diagnosis here. It's oligodendroglioma, IDH mutant, and 1p19q co-deleted. Histopathological classification is oligodendroglioma, and the grade is 2. I've just taken an example of a grade 2. And the molecular information here is that the tumor is positive for IDH1 R132H, which is a surrogate for IDH mutation. So we know that there is IDH1 mutation, and 1p19q is co-deleted by the FISH technique. So because we have all the molecular information, we're able to give an integrated diagnosis, and we're able to give an integrated CNS-WHO grade. There is another example, which same oligodendroglioma, which is IDH mutant, but I've called it NOS. Now, why have I called it NOS? Because here we have information that it is IDH1 R132H positive by IHC. In my center, I was able to do only IHC, and so it is. We know it is IDH mutant. We know it is oligodendroglioma by histology, but I'm not able to perform FISH on this particular case in my center. So since it's not a complete diagnosis, we have to say NOS. And once you give a NOS, you cannot give a CNS-WHO grade. You have to give a histological grade, because CNS-WHO grade is given only when you give a complete integrated diagnosis. I hope this is quite clear to the students. Now, what WHO CNS5 has done is it has introduced this essential and desirable diagnostic criteria for every tumor type. Essential diagnostic criteria are those that are definitive criteria. That means they must have feature for the diagnosis of a particular tumor. For example, for astrocytoma IDH mutant, IDH mutation is an essential diagnostic criteria. Whereas desirable diagnostic criteria are those that can support a diagnosis, but they're not mandatory for the diagnosis. For example, for this tumor called pleomorphic xanthoastrocytoma, large majority of them will show this BRAF-V600 mutation. Okay, it is characterized by BRAF-V600 mutation. But let me tell you, it is not seen in 100% of the cases. It's seen in about 70 to 80% of the cases. And that is why this is a desirable criteria. You can still make the diagnosis of PXA on histology without BRAF-V600 mutation demonstration. So this becomes a desirable diagnosis. So every tumor will have a essential criteria and a desirable criteria. Okay, and now what is this DNA methylation profiling? This is a very high throughput methylation profiling technique. What WHO CNS5 has done is it has used this technique to develop the classification. Now these DNA methylation profiling experiments were carried out way back in the year 2018 by the German group, by the Heidelberg group, where they profiled more than 2,500 tumors. Okay, and they generated a huge data because it's high throughput. You use a particular platform which will profile the entire methylation sequence of that particular gene. And what they found was they had a huge data that was generated, and they used appropriate bioinformatic tools, and they were able to plot this atlas where tumors could be classified very beautifully. And they showed that the methylation-based classification was much superior to the histology-based classification. But we know that we can't use this for routine diagnosis. The WHO CNS5 doesn't recommend that we use it for every case for routine diagnosis. Sure enough, it is a very effective way to characterize some of the very challenging neoplasms and to identify some new or rare tumor types and subtypes. But we know that it is technically challenging. You and me cannot perform in all the centers. In fact, there are so many centers which have very basic IHCs. They don't even have surrogate IHC markers. So where can we perform DNA methylation profiling? And of course, there is the cost factor also. So what WHO CNS5 has done is it has made DNA methylation profiling as a desirable criteria for most of the tumors. It's not essential. It is essential for very few tumor types. I've given just 2 examples. One is high-grade astrocytoma with pyloid features, and one is a new tumor type known as a diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. You don't have to remember this. Just remember that it is an essential criteria only for few tumors and a desirable criteria. We still can make the diagnosis without this DNA methylation profiling. Now you can see this is how the tumors are classified in WHO CNS5. We have these 12 major groups of tumors. Each major group will have these smaller groups of tumors, and each smaller group will have tumor types, several tumor types. So I'm supposed to be discussing the adult type of tumors, particularly with reference to these gliomas. But let me tell you that the tumors that occur in the adults can also occur in the pediatric age group and vice versa. Nevertheless, now what are all in the yellow fonts are the tumors that predominantly occur in the adults. Adult type diffuse gliomas, cranial and paraspinal nerve tumors, meningiomas, mesenchymal non-meningothelial neoplasms, melanocytic neoplasms, hematolymphoid tumors, tumors of the cellular region, and metastatic tumors. These are predominantly in the adults. And what are in the white fonts? That is the pediatric type, low and high grade gliomas, ependymal tumors, embryonal tumors, and others. They're predominantly in the pediatric age group. And the ones that are in the orange fonts, like the circumscribed astrocytic gliomas or the glioneuronal and neuronal tumors, they occur in the young adults or sometimes in the older children. And as I told you, each of these tumor groups can have several tumor types. For example, the adult type diffuse glioma has 3 tumor types, which we are going to discuss. The group of glioneuronal tumor has 14 tumor types. So every group will have several tumor types. Some of them are genetically defined, some of them are histologically defined, and some of them are both genetically and histologically defined. So now we will focus on gliomas because that is what we're going to look at, and mainly the adult type of gliomas. And this table, it shows you how the gliomas were classified in WHO 2016 versus this WHO 2021, which is WHO CNS5. In the earlier classification, all the diffuse gliomas, they came under this header called as diffuse astrocytic and oligodendroglial tumors. It had several molecularly defined tumor types. Of course, NOS was also used at that point of time. Almost 15 molecularly defined. They were called as tumor entities at that time. Now we call it as tumor types. And all the other circumscribed tumors came under this other astrocytic tumor. So this was a previous classification. But now you can see that the classification is much simplified. We have these groups: adult type diffuse glioma, pediatric type diffuse high-grade gliomas, diffuse low-grade gliomas, and circumscribed astrocytic gliomas. And each of them will have several tumor types within that group. So one of the major changes in this glioma classification in WHO CNS5 is the division of these diffuse gliomas into adult type and pediatric type. It was not there in the previous classification. Only now we have adult type and pediatric type because we know that they're molecularly distinctly different neoplasms. And the division of pediatric diffuse gliomas into pediatric type high-grade gliomas and pediatric type low-grade gliomas. However, you should remember that the pediatric type diffuse gliomas can also occur in the adults, and the adult type diffuse gliomas can occur in the pediatric age group, although their genetic background is mutually exclusive. For example, adult type diffuse gliomas are heralded by these mutations, either IDH mutation or 1p19 and or 1p19q co-deletion, whereas the pediatric type diffuse gliomas, they usually harbor histone H3 mutations, or they may show alterations in the RAS MAP kinase pathways. This is the most common alteration that you see in this. But of course, there are so many other alterations also that have been described. So please remember that the tumors that occur in pediatric age group can occur in the adults, adult age group can also occur in the pediatric age group. So now let us come to our group of tumors, that is the adult type of diffuse gliomas. And let me tell you that this is a genetically defined tumor group. The three tumors are genetically defined. Which are the three tumor types? It's astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q co-deleted, and glioblastoma, that is IDH wild type. Now, astrocytoma IDH mutant has three grades. I told you there is grading within the tumor type. The three grades are referred to as CNS WHO grade 2, grade 3, and grade 4. And what was called as diffuse astrocytoma IDH mutant grade 2, anaplastic astrocytoma, and glioblastoma no longer used. So you don't use these terminologies anymore. You don't use Roman numerals for grading. You use only Arabic numerals for grading. So this is what we are following, and this has become obsolete. And astrocytoma IDH wild type, this is eliminated. So we don't have any astrocytoma IDH wild type in the adults. These become glioblastomas. And if it is, or can be any other pediatric type of an astrocytoma IDH wild type tumor, which I'm not going to discuss. But remember that astrocytoma IDH wild type terminology is eliminated. What about oligodendrogliomas? Oligodendrogliomas are defined by IDH mutation 1p19q co-deletion. You cannot make a diagnosis otherwise. And they have two grades, CNS WHO grade 2 and grade 3. And we don't use the previous terminologies and the previous grading. Anaplastic oligodendroglioma, the terminology is not used. You just say oligodendroglioma, IDH mutant 1p19q co-deleted, CNS WHO grade 3, and don't use the term anaplastic oligo. Okay. What about glioblastoma? Glioblastoma is only IDH wild type. Earlier we had IDH wild type and IDH mutant. That is not there anymore. Now it is only IDH wild type, and you designate it as CNS WHO grade 4, and 4 is denoted in the Arabic numerals. I hope this is clear to you. The three genetically defined tumor types in adult type of diffuse gliomas. Okay. So with this, we will, I think with this introduction, if you have any doubts at this point of time, maybe you can put it in the chat box, or we can discuss it subsequently. But we'll start with the cases because then all these will become more and more clear to you. So the first case, case number 1, will be discussed by Siddhi. Siddhi, are you there?
Yes, ma'am.
So you can discuss this case.
Okay, so we have 32-year-old man presented with generalized tonic-clonic seizures for 2 months, headache and vomiting for 15 days, and left-sided weakness for 15 days.
So what can you make out of this history, Siddhi? So yes.
The tumor is basically belong to the adult age group, yes. And it is presenting with seizures, so it might presses any brain organs at that. So radiologically we can see something.
No, don't worry about radiology. Let us look at only the history. So there is a generalized tonic-clonic seizures in this patient, isn't it? So maybe white and gray matter of the brain is involved. And look at the duration of the symptoms. What do you think?
It is on acute onset.
Acute onset, very good. So it is not a very chronic one, isn't it? It is not going on for many years. It's acute onset. And then the patient has headache and vomiting for 15 days. What do you think that is because of?
That is because of the lesion that presses and now
no, because of the increased intracranial pressure. There will be increased intracranial pressure. That is why there is headache and vomiting, and there is a left-sided weakness, which means that the lesion is located on the on the right side, isn't it? On the right side, it's located on the right side. Anyone else also can answer. I have no problem with that. Okay, so that is what the history tells us. Let us look at this image, and can I request Kajri? Can you just briefly describe this image to them?
So, ma'am. So can I annotate actually?
Yeah, please.
So request.
Do you want me to annotate? Yeah, let me just pointer option. I'll take the pen. Okay.
So the thing is that there are 4 sets of actual images. So what we are seeing basically, first is written as a T2 flare, second is written as T2. So whenever we are commenting on any kind of brain MRI imaging,
you can request for annotation from.
Yes.
Yeah, I will annotate. As she's telling, I'll annotate.
Ma'am, I've got that annotation, whatever the control. So I'll start now.
Yeah, sure.
When we see the T2 weighted image, so it is very important for all the residents to know that the base image for any kind of MRI brain is a T2 weighted image. T2 weighted image gives you an idea about where is the location of the tumor, whether it is located in the gray matter, in which side it is located, and what is the tentative histology that we are expecting. Because what happens is that generally lower grade tumors, they are more homogeneous. That means they have a similar signal on, so they are generally homogeneous, and there is a little bit hyperextent on T2. As the tumor grows high in grade, it has some intrinsic hypointensity. And when I show my cases, I'll show you how do the tumors evolve from lower grade to higher grade. So basically coming to this case, what we see is there is a lesion here which is present in the right insular region, and it is also, so this is the region of the basal ganglia, and this is the insular, if we compare on the normal side. On the contrary, so this is another thing, this is the left and this is the right side we are looking at, right? So here we are looking at the right region, which is involving the insular cortex. It is also involving the basal ganglia and the posterior limb of internal capsule. So all the clinical features are the same. Number 1, patient has generalized tonic-clonic seizures. As we can see, the cortex is involved, so therefore that can be pure generalized tonic-clonic seizures. We can see that there is involvement of the posterior limb of the internal capsule, which is this on the left side, so that is involved, and therefore the patient is having weakness on the contralateral side. And other than that, we can see there is some midline shift. So we can see here this tumor is exerting some mass effect, and it is causing the midline shift to the opposite side. So therefore the patient has features of raised intracranial tension, and therefore patient is having vomiting and headache. So this is the first thing. Other than that, we see the tumor is basically hyperintense, so it is bright, or it is giving a white signal, not T2 weighted image. Next, we see this flare. So what we see is this is your T2 in which the lesion predominantly appears bright. In flare, there are some areas of inversion. Inversion means that whatever is appearing bright on T2 is showing some amount of signal drop. It is becoming a bit hypointense, not flare. What it signifies is that basically, if you see here, these two sequences are exactly similar, except the PSS signal. So if you see that fluid is hyperintense on T2 and it is black in flare. So what happens is that means that the it's a very specific sign which is called as the T2 clear mismatch, which is seen in IDH mutant astrocytoma. Also, there is some grade of it. So if it's more than 50%, it is considered 100% specific of IDH mutant astrocytoma, but the sensitivity of the sign is low, it is around 40%. So apart from that, that include diffusion and the blue light that we don't have then. So what we see is the T1 weighted image. This is needed when we see the post contrast. So what we see is basically the tumor is hypo-intense on T1, so it's dark, so hypo means dark. So it's hypo-intense in T1, and what we do is we compare it with this side, that is the post contrast. We see there are two of post contrast enhancement. Enhancement means these are appearing a little bit brighter. And if we just correlate it with this particular image, these two areas are a little bit dark. So there are some areas which are showing some features of higher weight, that is, they are appearing a little bit dark on T2 and they're showing some enhancement. So that's what it's like. So another very important thing is when you look at the margins of the tumor, so if I would remove the annotations and drop this, is there any way? Okay, so,
I'm not sure, but
okay.
yeah.
Margins of the tumor that you see, they are not very clear, they're not crystal clear. When we come to later cases, we will see that these the margin of the tumor is very clear. So this is a very the margin of the tumor is not that crystal clear, and that is therefore it's a diffuse region. So basically, this is a diffuse astrocytoma, and due to this mismatch, I would say that it is a IDH mutant astrocytoma. There are some areas of higher weight, is what I see. Now I request one.
Yeah, so she has described very beautifully. I hope you were able to understand, all of you. So she has shown you what these images are, and she's told you it is hyperintense on this T2, and whatever was hyperintense had to be hyperintense here also, but there is an inversion, and that is known as T2 flare mismatch, and one of the features of IDH mutant astrocytomas on radiology. So that is actually, it is a radiological biomarker. So let us go to the next one.
Just click in the center. Just click in the center of the screen.
Yeah.
Next slide. Click in the center. Just click in the center of the screen.
Okay.
Next slide.
Okay, that's good. That's good. So now, Siddhi, can you describe? We have some histology images. So the lesion was subtotally resected, and then you can see that this is how the lesion is. This is how the histology is. Please describe.
So we can see here as a various size cells with might be hypercellular areas, and somewhat mitosis is also there, and abundant eosinophilic cytoplasmic cells are also seen, and some areas showing vascular proliferation also.
So what do you think these cells are?
These cells are astrocyte cells.
So you should say that first to begin with only, isn't it? So if you just say cells, no one can make. See, whenever you describe histology in any tumor, whichever, first you have to talk about the tissue pattern, cell type, and cell characteristics. Okay. So this is sort of a cellular tumor. You can see here it is very cellular on this right one, isn't it? So let me just change my pointer option. I'll take a laser pointer now. So here it is very cellular. It is infiltrative, and then you have a stroma in the background, isn't it? Thin fibrils are there in the stroma. These are all what stroma do you think that is? What is that stroma? Is it a mesenchymal stroma? Is it a glial stroma?
Glioblastoma.
It's a glial stroma, isn't it? So they're all infiltrating on this glial stroma, which are having these small spaces here. Can you see the spaces in the stroma? What are these spaces? They are referred to as microcystic spaces. So you have a fibrillated glial microcystic stroma over which these astrocytic cells. You can see that different cell types you can see, but all of them have an astrocytic morphology. This is very cellular, and then you can see that some of them there is nuclear atypia, very significant nuclear atypia. What do we mean by nuclear atypia? Increase in the size of the nucleus, multinucleation, hyperchromatic nucleus, intranuclear cytoplasmic inclusion. All that comes under nuclear atypia. So there is significant. You can see some of them have abundant cytoplasm like a gamestocyte. Some of them are fibrillated. Some of them are roundish, almost look like oligo, isn't it? See here, some of them are looking like oligodendrocytes also. And you're right that there is mitotic activity over here. Okay, so that is good. We'll go to the next slide. I don't know why this is not moving. Let me change the pointer option and.
Okay. So go to laser pointer.
No, I wasn't laser pointer, but.
Just click in the center. Click in the center of the screen, and let's move now. It is not moving.
No.
Or maybe you'll have to erase everything what you've done. Just click on the right side, and just go to the pointer option. Just say erase, eraser, all ink on the slides. All ink.
Yeah, I'll erase all ink on the slide. Okay.
I think
so. Now I'll go to pointer option and I'll just take a laser pointer now. Let us see whether it comes. No, it's not coming. So I'll erase this.
Very good.
Maybe I'll just take an arrow option, which is automatic.
What happens when you click in the center? Can you move? You can't move the next slide.
No, it's not.
Stop sharing and share again.
Okay.
Yeah, you can share again now.
Sorry about that. Okay, I'll share this again.
Perfectly fine.
I'll share again.
Yeah. After a long time, we have a good audience today. So 270 students to listen to you.
Assuming there is some problem with this.
No, it'll just click in the center of the screen, and move your from the key from the keyboard. Next.
Okay. I got it. There you go. Okay. Now this is a higher magnification. Siddhi, can you describe the cell types over here?
Yes, there are hypercellular areas which contain astrocyte with highly atypical cells, which some of them have abundant eosinophilic cytoplasm, some are showing mitotic activities, some are showing binucleation, and vascular proliferation also seen.
Where is vascular proliferation, ma? There is no vascular proliferation. There is no blood vessel. I'm not able to see.
Sorry, ma'am.
Microcystic spaces.
Okay.
These are thin vessels. They are the native vessels. They are proliferating. The thin vessels are there, but you're not seeing any microvascular proliferation. I'll tell you what is microvascular. Have you seen this multinucleated pleomorphic cell?
Yes, ma'am.
Yeah, so binucleate, multinucleate, astrocytes, gamestocytes, and brisk mitosis. In one field, you can see two atypical mitosis, isn't it? So let us look at the next slide now. This is again the same thing. You can see this abnormal mitosis. So many mitotic figures over here. It's very malignant. And you can see this pleomorphism. You can see binucleate cells. Some have abundant cytoplasm and some have this. So this is the higher magnification. So I've given you some diagnostic IHC markers. I've given you these two markers. Siddhi, can you tell me what are these and what does it show?
The GFP IHC is positive.
What is GFAP? What is GFAP?
Glial fibrillary actin protein.
Glial fibrillary acidic protein. Very good. GFAP is glial fibrillary acidic protein. Write down. Okay. Okay, it's an intermediate filament protein. And what has happened here? What does it show in this slide?
Positive for the malignant cells.
No. Come on, tell me properly. Only cells are positive. Or only anything else is positive?
Background is also positive.
Very good. You can see that the cells, cytoplasm, the tumor cell cytoplasm is positive, plus the fibrils that come out of the cytoplasm, which form that fibrillated stroma. The whole thing is positive. Okay, that is what GFAP will stain. It will stain not only the cytoplasm, but all the glial fibrils. And that is why it's a glial tumor. It is GFAP strongly positive. That is why we say it is GFAP positive. And what is this? Olic 2, and you may not have seen this, I will explain. This is Olic 2. You can see a nuclear stain which is diffusely positive. Olic 2 is a very good stain that we use for all these diffuse gliomas. You can ask me what is Olic 2. Olic 2 is a very important transcription factor. It is essential for the specification and differentiation of these cells for oligodendrocytes, astrocytes, and neurons during development. So Olic 2, it gets universally expressed in all the differentiated oligodendrocytes, in astrocytes, in oligodendrocyte precursor cells, or what we call as oligodendrocyte-like cells. It will be positive in them. In immature neuronal and neurocytic cells are also Olic 2 positive, but it is not expressed in differentiated neurons, primitive neuroectodermal cells, ependymal cells, or microglial cells. So Olic 2 is negative in all that. So Olic 2 is always positive in these diffuse gliomas. So even in some of the circumscribed gliomas also it will be positive. So for example, you want to differentiate a pilocytic astrocytoma from an ependymoma. Okay, an ependymoma will be Olic 2 negative, whereas pilocytic astrocytoma will be Olic 2 positive. So it's a very useful stain, and we use it for all these diffuse gliomas. So that is why I showed you that it is you use GFAP and Olic 2. And what is this stain, Siddhi?
This is MIB1, also called as Ki67, which is used for counting the proliferating cells, counting the mitosis.
Not mitosis. Mitosis is
Proliferating
different. Proliferating cells are different. Okay, because when a cell proliferates, it goes from G0, G1, G2, S phase, and M phase. M phase is the mitosis, but cell in proliferation can be in any of those phases. And this antibody will label those cells which are proliferating. It may not be in a mitotic phase, but proliferating. Okay, understood? So yeah, and MIB1 is actually a commercial antibody. It is from a company called DACO against the Ki67 antigen. You can use any other antibody also. So Ki67 antigen will label the proliferating cells. It does not label the mitotically active cells. It will label them also because it is labeling all the proliferation. If you want only for mitosis, there is a histone marker called as PHH3. Okay, that is known as a mitotic marker, but not Ki67. It's not a mitotic marker. So the way we make a labeling index is we'll count about 1,000 cells, particularly near the hotspots, and then we make a percentage. And 1,000 cells, how many are positive? Make a percentage of that, and then you'll get your percentage. And in this case, it was more than about 12 or 14%. It was very, very high in this particular case. So what is your preliminary diagnosis, and how do you want to proceed to arrive at the final diagnosis? What is your preliminary diagnosis?
WHO astrocytoma, WHO grade 3, IDH mutant.
Where am I? I didn't even show you IDH. How did you call it IDH mutant? Because Kajari told you. I didn't show you at all. Kajari, you gave away the diagnosis. You cannot. I have not shown you. I've just shown you the diagnostic markers. It is astrocytoma.
Grade 3.
That's all. You cannot say IDH mutant. So you want to proceed with the case, isn't it? So
Yes.
the preliminary diagnosis here will be a diffuse glioma compatible with astrocytoma. All right. NOS. Now we use NOS because we don't have any molecular markers and it's a molecularly defined tumor. Okay, we don't have a molecular marker, so we call it NOS. And because we are calling it NOS, we're giving a histological grade. And histological grade is 3. Did you understand? Students, have you understood?
Yes, ma'am.
So now let me ask you one more question. What next? What are we going to do? We are going to use surrogate IHC markers. So do you know of any surrogate IHC markers? You gave away the diagnosis.
We can use IDH.
Very good.
Then P53 we can use for.
Very good. Very good. And then
We can use ATRX.
very good. Excellent. 100 marks for you.
Thank
For this particular question, you've got full marks.
Thank you, ma'am.
So this is the first slide. First one, whatever you said. What is this?
Mani, sorry to interrupt.
Yeah.
There was a very interesting question. It actually crossed my mind also. Why not
Yes.
grade 4?
We'll come to that. We'll come to that.
CDK late.
Yeah, we're going to come
At
to
least I'm happy one of the participants has thought about that.
Very
Because the mitosis, MIB1
So,
index.
yeah. So let me tell you that if you're going to do a histological diagnosis, and if you wanted to call it grade 4, you had to see one or two more histological features. That is necrosis and or microvascular process. Then we could have called it grade 4 on histology itself. But now on histology, we're not calling it grade 4 because if you go back, we haven't seen that. No, we haven't seen microvascular proliferation and we've not seen necrosis. So histologically, it's not a grade 4.
Correct.
Histologically, it's a grade 3 tumor. But then we know that this is a molecularly defined tumor type. So that is why I called it a grade 3 and not a grade 4. So this is the first marker. Yes, Siddhi, your favorite marker.
IDH.
Very good. How I showed you initially how to denote that. Now, how will you say? IDH what?
IDH1 R132.
IDH1, you put a P dot R132H, okay? Because that is the sequence, amino acid sequence, all right? So this is R132H, IDH1, R132H. Did you understand? We'll come to that a little later. I will chew your brain on that also. Then your other two favorite markers. Let me tell you what they are.
Left side is ATRX and right side P53.
What does ATRX show?
Negative for the cells, malignant cells.
Negative for the cells. So we'll say that it is ATRX loss of expression. How can you explain that? When there is ATRX mutation, there is no expression. How can we explain? See, ATRX is a gene that is in the brain tumors mutated in the gliomas in two groups of gliomas. One is IDH mutant astrocytoma, and the other one is histone mutated pediatric type of gliomas. ATRX gets mutated. Okay. Now, ATRX was initially identified in other tumors. It was identified in neuroendocrine tumors and all. Then it came to the brain. Now, among these, the type of ATRX mutation is known as, it is a truncating mutation, okay? Because it is a truncating mutation, the protein is not expressed. So IHC is a good way to demonstrate this mutation because protein doesn't get expressed. So none of the tumor cells are positive for ATRX. So that will tell you that ATRX is mutated. But you must see that there are all these internal controls. The blood vessel, you see this blood vessel? Endothelial cells are positive. Some overrun native glial cells. There will be some native glial cells in the brain, isn't it? They will be positive. Neurons will be positive. If you have some tumor infiltrating lymphocytes, they will be positive. So you should look at the internal control. This is very important because it will also tell you that your stain is working. If you see a negative stain, it may be that your stain didn't work at all. So it also tells you that your stain is working, and this is the loss of ATRX expression, okay? And this is what? P53. P53 is strongly positive. It's not an essential criteria because not in all cases P53 positivity will represent TP53 mutation. Okay, only when there's a missense mutation, which occurs in most of the cases, you see P53 positivity. But if there are other types of mutations like splice site mutation or truncating mutation or even the deletions, then P53 will be negative by IHC. That doesn't rule out TP53 mutation. So P53 is only a supportive to ATRX. So we use P53 alongside with ATRX, which is very useful for a diffuse glioma diagnosis. So now we found DFAP was positive, OLIC2 was positive, ATRX was loss of expression, and P53 is positive. So the diagnosis now will be astrocytoma, IDH mutant. Even now it is NOS because we are not grading it. We have not put a CNS WHO grade. We have to give a CNS WHO grade. It's histologic grade 3. Okay. So we call it as astrocytoma, IDH mutant, NOS. Even now I'm calling it NOS. Okay. But now Before I go to the grading criteria, I'll just tell you the diagnostic criteria for IDH mutant astrocytoma. The essential criteria is that it's a diffusely infiltrating glioma with IDH1 or 2 mutation and loss of nuclear ATRX expression or ATRX mutation or exclusion of 1p19q codeletion. Sometimes this ATRX loss cannot be identified properly, or sometimes it need not be there also due to different type of mutation. In such a situation, you should do 1p19q and show that there is no codeletion. Okay. So, but we don't need to do that in all the cases. ATRX is more than enough, and all others are desirable criteria. We don't use, we are using p53, but it's not an essential criteria. Methylation profiling is a desirable criteria. And look at this, astrocytic differentiation by morphology is desirable criteria, because some of these IDH mutant astrocytomas may not look like astrocytoma at all. It can look like oligoastrocytoma. Sometimes it can even look like an oligodendroglioma. So that is the reason we say that astrocytic differentiation by morphology is only desirable, and it has to be diagnosed on molecular markers. And surrogate IHC markers are more than enough to make a diagnosis of this. Now, IDH is the most common mutation. Initially, it was identified in GBM. We don't want to go into that story. Later, it was shown to be a driver mutation in all diffuse lower grade gliomas in adults. Astrocytoma, oligodendroglioma, oligoastrocytoma, all those tumors had shown IDH mutation in the lower grades, in grade 2 and grade 3, and some in grade 4. And the two isoforms are IDH1 and IDH2. Both IDH1 and IDH2 can get mutated in these gliomas. And there are several mutations in IDH1, several in IDH2, about 6 in IDH1, 5 in IDH2. Okay. IDH1 mutation is more common than IDH2, and the most common in IDH1 is this R132H mutation. And luckily for us, that can be detected by immunohistochemistry. This is seen in more than 93% of the cases. So in most of the cases, it is R132H, and we can detect that by IHC. And only in those cases where IHC is negative, we have to look at the other mutations. We cannot, there is no other IHC for that. We have to do a DNA sequencing to identify the other mutations. Okay. So the most common mutation is IDH1 R132H. It is known as the canonical mutation. Others are non-canonical. Canonical by IHC, non-canonical by DNA sequencing. Any doubts? Did you understand this about IDH? So there are two isoforms, IDH1, IDH2, both can get mutated. IDH1 is more common. Out of that, R132H is the most common, and that can be detected by IHC. That is more than enough for you. All right.
I think we need to explain, because in clinical practice, the ATRX sometimes interpretation is not so great. And what is the threshold of doing the sequencing? In which case, pediatric type, adult type, forget the G34 and all that, that's known to complicate of ATRX loss. But if ATRX is lost and IDH is coming negative at IHC, when to do?
Yeah, so this is a very good question that Dr. Rakesh is asking. That is, IDH R132H has come negative, but then ATRX has come loss of expression. It may be in an adult tumor, it may be in a pediatric tumor. Now, the two tumors where there is ATRX loss alongside with p53 positivity in the adult will be IDH mutant astrocytoma, maybe grade 2, grade 3, grade 4. And in the pediatric, it will be pediatric type high grade glioma, which is that H3G34 mutant tumor. That will also show ATRX loss and p53 positive. How to differentiate the two? Very simple. You use one stain, which is OLIC2. OLIC2 is always positive in these adult tumors in the astrocytoma IDH mutant, whereas OLIC2 is always negative in case of pediatric G34 mutant tumor. So if you have IDH negative by IHC, so this is what I wanted to show you. If you have negative by IHC, if it is positive, don't bother to do anything. If this is negative in the adult, you make sure your OLIC2 is positive, and then go for sequencing to look for any other type of IDH mutation. In the pediatric age group, if OLIC2 is negative, then you know that you don't have to do IDH sequencing. You can go for histone sequencing, or you have IHC surrogate for that. H3G34 R and V are the Geeta will be showing it to you, and they're all the IHC surrogates for that. So please remember, OLIC2 plays a very important role. You can differentiate the pediatric type from adult type when ATRX is lost and p53 is positive. Now, this is very important. What WHO has done is that there is not only a why did I call it as NOS and histologic grade 3 and did not give a CNS WHO grade 3 is because there is a molecular criteria apart from histological criteria for grading these astrocytoma IDH mutant. We know that IDH mutant astrocytomas are grade 2, grade 3, and grade 4. Okay. Now, a grade 2 tumor is a very histologically very well differentiated, no anaplastic features, nil or low mitosis, no microvascular proliferation and necrosis histologically. And molecularly, it will not show the CDKN2AB homozygous deletion. A grade 3 tumor is what we saw just now. It is more cellular, it has anaplastic features, it has significant mitosis, but no microvascular proliferation and necrosis, what we saw in our case. And it will not harbor CDKN2AB homozygous deletion. What about a grade 4 tumor? A grade 4 tumor can look just like this. It can have necrosis and or microvascular proliferation. Then you don't need to do any other molecular marker for it. Histology more than enough. You have shown that it is IDH mutant by showing IDH1 R132H positivity, but you can see that it is grade 4 because of histology. Alternatively, it may have this histology. It may have grade 2 or grade 3 histology, and but it can show CDKN2AB homozygous deletion. Now, even then, it becomes a grade 4 tumor. So this molecular marker is very, very important. When in any grade 2 or grade 3 tumor that harbors a CDKN2AB homozygous deletion, automatically gets upgraded to grade 4. Please remember that. And let us see what has happened. What is the CDKN2AB? Now, CDKN2AB is cyclin-dependent kinase inhibitor 2A and 2B. It is a tumor suppressor gene. It's located on chromosome 9p locus 21.3, and it encodes for 3 tumor suppressor proteins. It's called P16, P14, and P15. What it do is that they inactivate CDK4, CDK6, or they prevent P53 degradation. And homozygous deletion will result in uncontrolled activation of several genes that are involved in the cell cycle. They transit from G1 to S6, make the cell very proliferative. And several studies, I just shown one study or two studies over here, but several studies have shown that when there is CDKN2AB homozygous deletion in IDH mutant lower grade astrocytomas, that was associated with a short overall survival. And that is the reason WHO CNSY has picked up this marker for molecular grading of IDH mutant astrocytomas. But let me tell you that the frequency of the CDKN2AB homozygous deletion is very low in grade 2 and grade 3. Studies have shown that it ranges between 0 to 12% in grade 2. In our own study, the study from my colleague Dr. Vaishali from AIMS is that we found not a single case coming positive in grade 2. It ranges between 6 to 20% in grade 3. We have seen it to be lower than 5%. But identifying even that small group of patients who has CDKN2AB deletion is important because that will be behaving very aggressively like a grade 4 tumor. So that is why the importance of CDKN2AB is given to this IDH mutant astrocytomas. And in our case, what happened? How do we detect CDKN2AB homozygous deletion? By the simple FISH technique. When you read about FISH technique, or you might even have seen those who are doing breast cancer work, HER2 you might have seen the FISH technique, or you might have read about it. So this is a technique where it's histology based, and then we look at interface nuclei in this technique. And here we use a probe against this gene that is targeting this gene, which is CDKN2A to be located at 9p21, and that is labeled by the spectrum orange. So it will give an orange color, and the control is on the centromere, that is the set9 on the centromere of chromosome 9, and that is labeled by green. So generally, each interface nucleus must have 2 green and 2 orange signals. But if it has 2 green and no orange signal at all, not even a single orange signal in more than 40% of the tumor cells, you call it as homozygous deletion. If it has 1 orange signal, you call it as hemizygous deletion. Don't bother about the hemizygous. You must see homozygous deletion. So Siddhi, can you tell me whether there is homozygous deletion in this or not in our case? Anybody else? Yes or no?
No.
Very good. There is no homozygous deletion. You can see 2 green, 2 orange in all the nuclei, isn't it? So there is no, because they're overlapping nucleus, it looks like many signals, but there is no homozygous. You are seeing orange signals. You should not see any orange signal to call it as homozygous deletion. So our case does not have evidence of homozygous deletion. And because it does not have homozygous deletion, do we upgrade the tumor or we keep it as 3? We keep it as 3. So the diagnosis is, now we give a full diagnosis. We give an integrated diagnosis and an integrated grade. Astrocytoma IDH mutant, CNS WHO grade 3. And this is how we put the layered diagnosis. I won't go into details, but IDH was positive, ATRX was lost, and there was no evidence of CDKN2A homozygous deletion. And that is the reason that we have given this as grade 3. Is that clear to you? So we'll go on to the next case.
Ma'am, before proceeding, there are a few questions from the Delhi.
Okay. I'm not able to see the chat box.
I'm reading to you.
Dr. Tala, I can just quickly tell. One quick 3 questions basically. One was, is necrosis enough to call it grade 4? Irrespective, there's no cellularity, there is no mitosis, there is no ATPR, but no MVP, but only necrosis.
It's definitely enough to call it grade 4 if it is an IDH mutant tumor. But let me tell you, as the grade becomes higher and higher, for sure there'll be increased cellularity and for sure there'll be mitosis. So we will not. I'm talking about an IDH mutant tumor. So we will not have a situation where it is looking which has no nuclear ATPR and with necrosis and it is IDH mutant. It can be there in some other tumor like pilocytic and all, but not in an IDH mutant tumor. Yes, we can call it grade 4. That's the answer.
No, the question was an IDH mutant only. Second question is importance of P53. It is just to diagnose between oligo or astro, or does it help in grading also?
P53, see, this is only a desirable criteria, but we find it very useful on day-to-day practice. It is only a diagnostic marker, no grading. You cannot do any grading with P53. It is only a diagnostic marker, and it goes hand in hand with ATRX. When there is ATRX loss and P53 positive, then we know it is astro. When there is no ATRX loss and P53 is negative, we know it is oligo. We'll be looking at the case subsequently. So P53 is meant only for diagnosis.
Third
So,
question.
yeah, third one.
Third is about which I'll make a comment later. CDKN2AB. Should we do it in every single grade 2, grade 3 IDH mutant tumor?
This is a very, 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 I mean, this is a question that almost all the clinicians will ask because, you know, we are also, we should remember that there will be resource limitation in most of the centers and whether you have the technical expertise or not. Let me tell you that, in my opinion, for a grade 2 tumor, there is no need to do this CDKN2AB, unless, of course, it has all those pragmatic criteria that it is looking on radiology, it is a large tumor crossing the midline, patient is older age, then you may want to do it. Recurrent setting, yes, we will want to do CDKN2AB, but I would suggest CDKN2AB for all grade 3 tumors. Because even if you identify that small subset, a small subset of grade 3 will have it. And a small subset also is very important because they will be upgraded to grade 4.
I must tell you, in the last 2 years or so, because we were all thinking whether we really need to do it because it's not available widely, the cost issue, and generally the feeling was IDH mutant, astrocytoma grade, ATRX loss looks like a astrocytoma grade 3 in a young person. They should do very well. The median survival is anywhere between 5 to 10 to even 12 years these days. In astrocytomas and in oligodendrogliomas, of course, if they have 1p19q co-deleted, even if it is grade 3, IDH mutant and ATRX will be retained in that. The median survival now with the adjuvant therapy is 17 to 18 years in spite of a grade 3 gliomas. Having said that, we have actually one case currently under treatment, young man of 35. Again, similar tumor like what Dr. Vani showed in case 1, right insular astrocytoma, WHO grade 3, MIP1 was hardly 5 to 6%, received adjuvant therapy very well. Within a year, had a progression and had weakness on the left side, had aphasia also, even if it was on the non-dominant lobe, and we did the CDKN2A and it came out to be positive. So now we are retreating him. So there is a subset of patients as a clinician, because the whole world is telling them the prognosis is very good, don't worry about it, it's not like a grade 4, IDH mutation is very good. Mind you, IDH is a driver mutation. So we have also now in the last 1 year or so, we are doing every case of CDKN2A in all grade 3. I also do sometimes in grade 2, if you suspect a sampling error.
Okay.
That on MRI, it does look like you saw the mismatch sign and you saw the midline shape, there's some enhancement, perfusion is high, there is restriction on the diffusion scan, signifying cellularity, but the sampling is such, maybe it is in the dominant lobe on the left side or an allopant cortex, there's only a small tissue, and this histology cannot say grade more than grade 2. And those also we are now doing CDKN2A. I think these are relevant and which everyone should know. Dr. Tala, any question more? I may have missed more questions you will have.
I think that last point was very, very important what you said, Rakesh. And
One of the questions is that in the case of, in your experience, in oligodendrogliomas, whether 1p19q co-deletion is positive in 100% of the cases.
I'm not able to hear you. There's some kind of echoing from you, Tala.
Am I audible?
Yeah.
There is a comment from Dr. Babita. She said that in oligodendrogliomas, whether 1p19q co-deletion is positive in 100% of the cases. What is your comment on this?
It's a defining molecular marker. You can't call it oligodendroglioma without 1p19q co-deletion. So it is correlated in 100% cases. Okay. That's why it's a defining molecular marker. And there is no oligo without IDH mutation and without 1p9. They're different tumors. They're not oligodendroglioma, IDH mutant and 1p19q co-deleted. Okay. Several tumors can look like oligodendroglioma. In pediatric age group, we have so many tumors that look like oligo, but they will not have 1p19q co-deletion. They'll have different molecular alterations. So
Except diffuse gland-neuronal tumor.
It's called as diffuse gland-neuronal tumor with leptomeningeal tumor, that is DLGNTs. They have isolated 1p deletion. Usually don't have 1p19q. They have isolated 1p.
We had one case where they have co-deletion.
Occasional cases have co-deletion, but they have a MAP kinase pathway alteration also, and most often it is a BRAF fusion. You should show both. Apart from 1p19q, 1p or 1p19q, you should have MAP kinase pathway alteration, like a BRAF fusion.
Very rare,
so very rare. They're rare tumors, so that's a diagnostic criteria actually.
But the more interesting question, Dr. Vani, is we don't have 1p19q fish. Classic oligomorphology, ATRX retained, IDH mutant. Do we need fish?
So I think me and Rakesh have been discussing this for many years now.
Yeah.
See, if it is an adult tumor and it has a very typical histology, a typical radiology, without that T2 flare mismatch, a very diffuse, irregular or indistinct margin, some calcification, cortical thickening, whatever it is, Rakesh knows better than me. So typical radiology, typical histology, adult patient, IDH is mutant, you call it oligodendroglioma, IDH mutant, NOS, whichever grade it is. Just go ahead and treat that patient. Okay. There is no need to do 1p19q if there is a resource limitation or you don't have that facility. So that term NOS is provided by WHO for that reason only. We have to put that term NOS, which is just a red flag. It doesn't mean failure from on the part of a pathologist. It doesn't mean that. It means that in your center you did not do that, but you know for sure it is oligodendroglioma IDH mutant, and you're saying that it is NOS, which the clinician can read it. Whoever is reading it will say, okay, this is oligo. I'm going to treat it as oligo, and then we'll see later. But there may be some clinicians who will say, no, I'll send it to another center because I would want to know. And there may be some patients who will want to know. I want to know whether my tumor is 1p19q correlated because he or she may feel quite gratified after seeing that it is 1p19q
And
correlated.
ATRX retain also will help a little bit.
ATRX retains. Now there are surrogate molecular markers. I don't want to take you on to those surrogates in this session because I will do it separately on a clinical session with surrogate markers, because now we are trying to put guidelines as to how we can diagnose these tumors when there is resource limitation. So don't worry about that. But the answer to Tala's question is that oligodendroglioma 100% are 1p19q correlated along with IDH mutation. Second,
Continue.
I think we can't do 5 cases today. We may be able to do only 3 cases. So you need to stop me at some point of time.
Vani, there are so many audience today, and there will be questions. You decide. Please take it easy. Whichever way.
Yeah, because I'm going to go till 12 midnight otherwise.
No, I think you take your time. Take your time.
So we'll Akshpita, can we have the next case from you?
Yes, ma'am. We have case.
On your video, please.
We have case 2, 35 years old male, presented with generalized tonic-clonic seizures for a year and with no neurological deficit.
So what do you make out of this history? What do you see?
It's since 1 year.
Compared to previous history, is
yes,
this different?
Yes, previous history was acute and this one is chronic because it has been 1 year since
Very
there is no neurological deficit the patient has.
Do you think it's deeply located or it's very superficially located?
Ma'am, it can be deeply located.
You think so? We'll have a look at the scan. Okay, good.
Unlikely, because it is seizure. That means a cortical tumor.
Yeah,
No
we don't have it. Yeah, that's why there is no neurological deficit. If it was deeply located, the patient would have had some weakness of the left upper limb, right upper limb, whichever, lower limb, upper limb, whichever side the tumor is, the opposite side there would have been. But here I'm telling you that it is only seizures and there is no neurological deficit in this patient. Okay.
Yes, ma'am.
So now we'll see this and ask Kajri to come in.
Yes, ma'am.
One sec, Kajri.
Ma'am, voice is audible, no, ma'am?
Yeah, your voice is only problem is I'm not able to move it again.
Just click in the center and use your keyboard.
Yeah.
Okay, so we are looking at again 3 sets of images. So first we go to the most right hand side image, that is the T2-weighted image. Again, if you look at the margins of these tumor, again it is a diffuse tumor. So the margin of the tumor is not well delineated. And if you see the location of the tumor, we see that it is located in the gray matter. So rather the subcortical white matter extending into the gray matter. So it's predominantly a subcortical white matter lesion which is infiltrating into the cortex.
Can you point?
And point. Yeah. So I have to request the pointer. Yeah.
Keep talking and I'll point it out.
Yeah. So what we do again, what we see here is that yeah. So this is your T2, right? So what we see here is it's a diffuse tumor. It is present in the subcortical white matter. It is infiltrating into the cortex. And if you compare with the last case, this is the flare image. We don't see any inversion. So basically, whatever is the signal in T2, it remains constant in the flare also. So unlike the previous one, which had a T2 flare mismatch, this one does not have a T2 flare mismatch, and I don't have a contrast image of this. So basically, what I can comment is it's a diffuse glial tumor which is present in the subcortical white matter, and there is involvement of the overlying cortex. It is present in the left parietal lobe, and it does not have any significant mass effect because we can see there is no midline shift or any perilesional edema which is causing mass effect. So therefore, the patient does not, and the location of the tumor is in the region that it is not close to the motor cortex also. So therefore, the patient does not have any deficits, but obviously this cortical location is responsible for the patient's features. And unlike the previous one, there is no T2 flare mismatch. So
let me tell you that there was no evidence of enhancement post contrast.
Okay.
I don't have that image, but it wasn't there.
Other than that, in this particular case, I would also like to have a look at the diffusion and gradient, because gradient can give an idea whether any subtle calcifications are present in this tumor. And in all probability, looking at the location of the lesion, I would put my diagnosis as an oligodendroglioma.
Grade 2 or grade 3?
I think if there is no enhancement and no heterogeneity, it should be a grade 2 tumor.
Grade 2 tumor. Very good. So we'll move on to the next. Okay. Yes, okay. Can you describe this slide?
See the closely packed cell with small round monotonous nuclei and microcalcifications are there.
Is it closely packed? Are they closely packed?
Ma'am, not that
Not diffused. Are they not loosely dispersed?
yes, ma'am, in this one they are usually dispersed. And ma'am, there are microcalcifications present.
These are all the microcalcifications.
Yes,
so
ma'am.
it's loosely dispersed once again on a glial stroma or not on a glial stroma? It's,
Ma'am,
do you think it is somewhat diffuse? It is spreading diffusely. Can you make out?
Yes, ma'am, on a glial stroma.
On a glial stroma, isn't it?
Yes, ma'am. Microcalcifications. Ma'am, here we can see the
Slightly higher magnification.
We can see these monotonous nuclei which are slightly larger than the normal oligodendrocyte, and we can see perinuclear clearing, also known as fried eggoparents, which is a formalin artifact. And we can also see the network of thin-walled branching blood vessels and ma'am, the presence of these perivascular aggregates of these tumor cells.
So you think that what would you opine? Let's go to the next and then you can opine. Yeah. Now you describe the cell type. First you said that it was low cellularity, moderate cellularity, or high cellularity.
Ma'am, this is in this slide. Ma'am, higher cellularity is there.
Moderate. In all the three, it is moderately cellular. Okay. And then you can see that the cells are dispersed on a glial stroma. They're thin branching vasculature, but no typical chicken wire vasculature. There is calcification. Now describe these cells. Describe the cell type.
Ma'am, the individual cell, there is perinuclear clearing is there. Ma'am, nucleus show a vesicular chromatin.
It is round cells with perfectly round nucleus, salt and pepper chromatin, and a perinuclear halo, very characteristic of a differentiated oligodendrocyte. Isn't it?
Yes,
huh? Are you convinced?
Yes, ma'am.
Because are also convinced that there are oligodendrocytes that are proliferating. So these are all the neoplastic oligodendrocytes that are proliferating. Now I'll show you diagnostic IHC markers. Yes, Akshpita.
Ma'am, this is positive for GFAP.
What is positive? As compared to the previous one, is it similar to that or different from that?
Ma'am, mostly similar. Like the background tissue is also.
First, you talk about the cytoplasm of the cell, then the fibrils in the background.
Cytoplasm haven't stained that well, but the fibrillar background
Cytoplasm is negative. Look at
negative
this.
staining, yes, ma'am.
It is negative. Tumor cells are negative for GFAP, isn't it? What is positive?
Ma'am, the background
The
glial
glial stroma is positive. So you must remember that oligodendrocytes are negative for GFAP. Unless you have some other cell type in oligodendrocyte, oligodendrogliomas. There are cell types called as mini gamestocytes, gliofibrillary oligodendrocytes. They will be positive, but not the cells with the perinuclear halo. They will be negative for GFAP.
Yes.
But the stroma will be strong because it is a glial tumor. It is proliferating on a glial stroma, isn't it?
Yes, ma'am.
And OLIC2 is positive or negative?
Ma'am, positive.
Diffusely positive. It helps us, isn't it?
Yes,
We like the stain a lot. I showed you why it is very important.
Yes.
And so OLIC2 is positive.
Positive.
And how is the labeling?
Ma'am, low index, low MIB than index.
Low index as compared to the previous one.
Previous
isn't
one,
it?
this is low, yes.
So this is very low. So what is your preliminary diagnosis and how do you want to proceed with the case?
Ma'am, preliminary diagnosis is oligodendro.
Very good. Very good. But do we want to use the term NOS?
Yes, ma'am.
We use the term because it's a histological diagnosis.
Histological diagnosis.
Now we don't have any molecular markers. It's a molecularly defined tumor. And now we have only histology, isn't it?
Yes,
So
ma'am.
it is diffuse glioma compatible with oligodendroglioma.
Yes, ma'am.
NOS. Histologic grade is 2 because you said that it is low grade.
Low grade,
So I
yes.
agree with you on that. What next?
Ma'am, then we'll do IHC markers.
Surrogate IHC
Surrogate
molecule.
IHC, yes.
Same
Ma'am.
markers or different markers? What we saw in Astro.
Ma'am, here we can do almost same markers.
Almost means what? If you want to.
Ma'am, IDH1 will do.
Then?
Ma'am, P53.
Very good. And then?
Differentiate.
ATRX.
ATRX. We'll do all of them. The same markers what we did for astrocytoma IDH mutant.
Yes, ma'am.
So what is the stain on the left and what is the stain on the right?
Ma'am. Here cytoplasm is.
This IDH1. So IDH1 is a cytoplasmic stain. You can see that the cytoplasm is, even the perinuclear halo, you can see how the cytoplasm is taken. In fact, oligodendrogliomas are more strongly positive for IDH when compared to astrocytomas. They're much more strongly positive. And what happened to ATRX over here?
Ma'am, positive. The clear area.
You either say loss of expression or retained ATRX.
Retained.
Are you sure? Is it lost or is it retained? Be confident. It doesn't matter if you're wrong.
I'm retained.
Very good. It is retained. Why should you feel so hesitant? It is. You saw how it was when it was lost, isn't
Yes,
it?
ma'am.
It is retained.
Retained.
Excellent. Very good. Very good. Full marks for you. Now I have done this stain.
P53 it is negative.
Negative, isn't it? So we have ATRX is positive. IDH is positive, ATRX is retained, and P53 is negative.
Negative. Yes,
So
ma'am.
what is the diagnosis?
Now we can say oligodendroglioma.
What?
Moderate.
IDH.
IDH mutant, you can say,
mutant, yes, ma'am.
but still you have to say NOS because you need one more marker, isn't it? What was the other marker that you require? I answered Tala's question, no? Somebody had asked.
1P19.
19Q. So that's why it is oligodendroglioma, IDH mutant, NOS, and because we are saying NOS, we are giving a histological grade. We are not giving a complete CNS WHO grade.
Yes.
Next, what should we do? Test for? You're right, you're right.
Sure.
You can tell me. For which marker now? We have already done IDH. Which is the next marker? 1P19Q, isn't it? And how do we test for that? Again, we do the fish assay. It is tested by fish assay. Here we use two probes. Okay, one probe is for 1P and one probe is for 19Q. We have a test and a control for 1P. The test for 1P is at 1P36 locus. The control is at 1Q25. And for 19Q, the test is 19Q13 and the control will be 19P30. So we use two probes. In every interface nucleus, you must see two green and two orange. Normally, when it is not co-deleted or not deleted. But here you can see that there is two green and one orange signal for 1P, two green and one orange signal for 19. Some cells have zero orange signal. Now, if you see less than two orange signals for 1P and for 19Q, less than two orange, it may be one orange or nil orange. In more than 40% of the tumor cells, then we call it as co-deleted. So in this case, if 1P and 19Q is co-deleted. Did you understand? Don't bother about which probe we use and all. It may be a bit too much for you at this level in your MD. Just remember, we have to do a fish test for 1P 19Q assay and demonstrate 1P 19Q co-deletion. Did you get that? Did you understand that? So now we have everything with us. We have, this is oligodendroglioma, it is IDH mutant, it is 1P 19Q co-deleted, and that is the reason we have given a CNS WHO grade 2. And this is the molecular information. It's always nice to put the diagnosis in a layered format. When you put it in layered format, the clinician who's reading it will know what are the tests the pathologist has done. See, each pathologist will communicate in his or her own way to the clinician. I mean, nobody should teach a pathologist that you do this, you do that. Each person has his or her own style. But if you do this, it's a sort of a synoptic reporting. It will tell the clinician, okay, this is how it is, this is the molecular testing they've done, and that is why they've given this diagnosis. And if we do not have any one of this, we would have given it as a NOS diagnosis. So these are the essential diagnostic criteria for oligodendroglioma. It's a diffusely infiltrating glioma with IDH 1 and 2 mutation and 1P19Q co-deletion. So you should have this to make a diagnosis of oligo. All others are desirable. Showing retained nuclear expression of ATRX and P53 negativity, third promoter mutation, all that helps in making the diagnosis. But they're not essential diagnostic criteria as per WHO CNS5. And we have two grades, grade 2 and grade 3. What we saw now was grade 2. Grade 3 was earlier called as anaplastic oligodendroglioma. We don't call that as anaplastic. We just call it as oligodendroglioma, IDH mutant and 1P19Q co-deleted, a grade 3 tumor. These tumors are more cellular, they have increased mitosis. Most often they'll have microvascular proliferation with or without necrosis. And the necrosis, when you see necrosis, it will be very focal. It won't be the diffuse confluent necrosis that you see in case of glioblastoma. So that is a grade 3 tumor. And there are these cell types in oligodendrogliomas. Remember, when you're looking at oligos, you may see different cell types. One is this mini gamestocyte. See, these are small cells that have gamestocyte-like morphology, but the cytoplasm is much more deeply pink in staining, almost acidophilic staining. You find that it will be very, very dark pink in staining. These are the mini gamestocytes. Gliofibrillary oligodendrocytes. Sometimes you can see these large cells. Some are spindle, some are polyhedral. They have this fibrillated cytoplasm that is, deeply pink in staining. So this can also be seen in oligos. And some oligos will have such granular cells. They're not eosinophil granular bodies. Tumor cells itself will have granular cytoplasm. And these cell types are usually seen in a grade 3 tumor. When you see such cell types, then you can almost be certain that you're not looking at a grade 2, but you're looking at a grade 3 tumor. Grade 2 tumors are very indolent. Only the perinuclear halo, low cellularity, diffuse infiltration, perivascular, and the perineuronal saccharitosis. That's what we will see in grade 2. But in grade 3, we see these sort of cell types. Not in all. When you see that, then it is easy for you to make a diagnosis. And the term oligoastrocytoma is deleted. It can be used as an NOS terminology, but if you do molecular testing, oligoastrocytomas either become molecularly defined astros or molecularly defined oligodendroblamas. So that's why the term is deleted. For example, look at this case. This case has both oligo areas and it has astro areas. Do you agree with me?
Yes.
There are these astro areas and oligo areas. So we just call it oligoastrocytoma NOS because we don't know what it is molecularly. But when we did the molecular IHCs, you can see IDH is positive, ATRX is lost, P53 is positive, and CDKN2AB was not deleted. So the tumor became astrocytoma IDH mutant CNS WHO grade 2. So with any oligoastrocytoma, if you do molecular markers, it will go into either molecularly defined astro or molecularly defined oligo. So the term oligoastrocytoma is deleted and we use it only as a NOS terminology. Is that clear?
Yes.
Both of you have done very well, Siddhi and Akshmita. You were able to diagnose the cases. I'm really happy. But I do want to know whether others have understood this concept, why we use these stains, and when we call a tumor as NOS, and when we call it as a WHO diagnosis. Okay? Is that clear? If there are any questions, I'll take it. Otherwise, okay, these are some key markers. Let me show you some key markers that we use for adult type diffuse gliomas. When the histology is either astro, oligoastro, grades 2 and 3. These are the markers, important surrogate markers, IDH1 and 2, ATRX, P53, Ki67, 1P19Q, and what is included is CDKN2AB. And here you can see that these are the technical platforms. For IDH1, R132H, for ATRX, for P53 and MIB, you can use the IHC platform. For the other IDH mutations, you use DNA sequencing. For 1P19Q and for CDKN2AB assessment, you use the FISH technique. Did you understand that? So these are the technical platforms, and these are the set of molecular markers that you require to make a diagnosis of astro or oligo. And astro grade 2, 3, 4, as well as oligo grade 2 and 3. Did you understand that?
Yes.
So with that, we'll go to the next.
One small point I want to make.
Yes, please.
Sometimes in tumor boards we realize this. There's a bit of necrosis sometimes. And if it looks like an oligodendroglioma, grade 3, of course. So the point is oligos will never be grade 4. Oligo has only 2 grades, grade 2 and grade 3. Even if it looks bad, cellularity, atypia, mitosis, even necrosis, you cannot go more than grade 3. That is one. The problem comes sometimes is there is oligoastro-looking cells, a lot of oligo-looking cells, but there is some astrostick and there is some necrosis. What do you do? So you call it oligoastro NOS, but do the 1P19Q. If the 1P19Q becomes correlated, you still call it, we used to call it anaplastic, now we call it oligodendroglioma grade 3. But if it becomes non-correlated, even if it is IDH mutant, ATRs can be either way, actually those times, then you call it grade 4 astrocytoma IDH.
Absolutely. Absolutely. I think Rakesh is a much better pathologist here. His concept is so good. He's really hit it. There's only one point that I want to make over here, Rakesh, and I didn't tell this to the students, that CDKN2AB also plays a role in oligodendrogliomas. A subset of grade 3 oligodendrogliomas which harbor CDKN2AB have been shown to have a very rapid progression. So, and grade 2s will never have it. It will never have a CDKN2AB homozygous deletion. It's not any criteria that WHO has brought in yet, but it does have a role even in oligodendrogliomas. So when you're having an oligo which has that necrosis and not behaving very well, radiologically not so good, it is worth doing CDKN2AB even in that case, because if it is showing deletion, then you have a problem with that patient. So that is one of the molecular marker which is not really there in the criteria, so I didn't want to confuse the students on that. So any other question? Rakesh, is there anything on the chat box? Anything is there?
I think it was okay. There were a lot of appreciation, but that's fine.
So we'll go to the third case. Most probably I'm going to end with the third case. Okay, we'll go to Sauvik. Are you there? Sauvik or Nagma, do you want to take the case? Who's taking the case, Sauvik or Nagma? Why so much hesitation? It's a very simple case. I'm telling you, it's very simple.
Glioblastoma.
Sauvik, please unmute yourself. Sauvik,
come on, it's such a simple case. Doctor, our chairperson has already given for the diagnosis. You can just go straight for it. Come on.
60-year-old male presented with sudden onset headache and vomiting for 7 days. There is left-sided hemiparesis for 3 days.
What does that tell you, Sauvik? What can you make out of this history?
It is an adult
What is
brain.
the impression? Yes.
It is an adult brain tumor and sudden
Just want to
onset.
say adult, or do you want to say older adult?
Older adult, ma'am.
Older patient, isn't it?
Older
60 years.
patient.
The others were all younger, isn't it? So this
Yes,
is a 60-year-old male, and what did he present with?
And sudden onset headache and vomiting. That means there is increased intracranial pressure and it is subacute onset 7 days. And left-sided hemiparesis indicate it has a compressive feature.
Very good.
Compressing with the motor.
Okay, so it is a tumor with a acute presentation in an older individual. So let us look. Kajari must come in now.
Yes, ma'am. Can I get the annotation? Yeah. So what we are seeing here, we are seeing only 2 images. The significance of these 2 images I'll tell you. So when we are looking at this particular area, this one is the post-contrast T1 weighted image. This is the left side. This is the right side. What we are seeing here is this. We should look at this. This is basically your central circus. So posterior to it will be a sensory and anterior to be motor cortex. So what we're seeing is this is a perirolandic lesion. What do you call it? This is the area which would be, if a lesion is present in this particular area, that will lead to your weakness. So what we are seeing is the patient is having weakness on the left side. So it is corresponding with the side of the lesion and the side of the lesion. Again, as compared to the previous lesions where the cortex was predominantly involved, we are seeing that the white matter is the area which is predominantly involved. So it's a predominantly white matter lesion. Second, the third thing is that there is significant perilesional edema. So these finger-like projections which we are seeing in the FLAIR image, these are all which signifies vasogenic edema. So there is significant edema which is also again contributing to the features of raised intracranial tension. As we can see, there is sulcal effacement and there is mild midline shift. So these will lead to raised intracranial pressure. And finally, if you look at the enhancement of this, it's a very heterogeneously enhancing lesion with a large area of central necrosis. So the radiology itself tells you that it's a very higher grade lesion. It's a diffuse astrocytoma definitely, but then there is necrosis and heterogeneous enhancement, which point that it is a glioblastoma.
Isn't it? So diagnosis is already very simple now. Sauvik, your job is made very easy, isn't it? So
Yes,
okay,
ma'am.
let me. Oh, okay. I'm not able to move this for some reason. Maybe you need
Stop annotating. I stopped annotating.
to stop annotating, but mine is not really moving.
So can you also try stopping annotation?
No, my right click is not working at all. I'm going to unshare and share again. Okay, I'm going to share again.
Maybe.
Okay. Sauvik,
Yes, ma'am. High cellular yield of, ma'am, I am explaining the left-hand side image.
very good.
There is high cellular yield of isolar pleomorphic population of cell where individual cell has a nuclear atypia, and there is also presence of high mitotic count, and there is microvascular proliferation, and along with that there is presence of one Brizard multinucleated giant cell.
So what cells? What type of cells are they? Astro, oligo,
Astrocytes.
pleomorphic astrocytes, isn't it? You can see
Yes,
different types of cells. They are spindle-shaped cells. They're arranged in closely arranged. Sometimes even have this vesicular pattern. Some little microvascular proliferation. Then they suddenly become very pleomorphic. Here they are spindle-shaped. They're large cells, gamestocytic
gamestocytic
morphology.
cells, yes, ma'am.
Yeah, binucleate cells, multinucleate cells. So
Large
you have all
eosinophilic
types of
cytoplasm.
cells. Yeah. So you call it as pleomorphic astrocytic cells. So now what has happened?
Ma'am, here in the left hand side image, I can appreciate spindle cell which is interconnected by reticulin fibers here in the left hand side, in the right hand side, and on the left hand side, ma'am, I can appreciate astrocytic cells.
These are definitely what is this area?
And this is sarcomatoid chain.
Here there is, I understand. Here
In
you
this
can see lot of
slide.
spindling, intervesicular arrangement of the tumor cells. So this looks a little bit like a sarcomatoid pattern. But here you can see that there is some necrosis, lot of myxoid change in the stroma. Can you make out that the stroma has undergone some myxoid degeneration? Lot of myxoid change. Some of these glioblastomas have a lot of myxoid change in the stroma. So that is what has happened over here. Okay, and high mitotic activity. There is no doubt about that at all. Now you tell me what is this? So you're there or you're not there?
Can you listen, ma'am?
Yes.
Yes, sir. In this section, ma'am,
Tell
I
me
can.
what is this and what is this? That's all I want.
This is, ma'am,
What
blood.
changes are they? Are they the changes in the stroma, changes in the tumor cells, changes in the vessels? In
Ma'am,
which-
changes in the stroma, ma'am. There is a blood vessels are present, ma'am.
What are those blood vessels called? What are these blood vessels?
Ma'am, these are tumor infiltration around the blood vessels, ma'am. Perivascular tumor cell infiltrations.
No, perivascular is but when you have numerous such thin blood vessels that come up, you call it as tumor neovascularization. Okay, they're all new tumor blood vessels that are proliferating, thin-walled blood vessels. You know what happens in glioblastoma is that the tumor cells, they throw out a lot of vascular angiogenic factors, several factors. And what they do is they would induct the endothelial cells from the surrounding brain parenchyma, bring it on into the tumor and form these new tumor blood vessels. But these tumor blood vessels they do not have a proper frame, they do not have a proper basement membrane, only the endothelial cells will be forming that. And because of that, it gives rise to extensive perilesional edema that you saw. Okay, so this is known as tumor neovascularization. Another term that is used is sprouting angiogenesis. We also use the term sprouting angiogenesis. Now, what is this one? Another vascular change.
Ma'am, there is a multinucleated giant cells, ma'am.
Glomeruloid
What is this? Is this a single multinucleated giant cell? These are the tumor cells.
bodies.
Glomeruloid bodies. What are glomeruloid bodies? Why does it come up like that? More simple terminology. It's called microvascular proliferation. Okay. Now the microvascular proliferation is very florid. Earlier we used to call it as endothelial proliferation, but now we know that it's not just the endothelial cells that proliferate. Along with endothelial cells, we have other cells lining blood vessel. Which are the other cells? Vascular smooth muscle cells, pericytes. All of them will proliferate to give rise to these structures. What you call as glomeruloid bodies, we call it as glomeruloid tufts because they resemble the glomerulus of the kidney. That's why you call it as glomeruloid tufts. So this is the typical microvascular proliferation that you see in which tumor?
Ma'am, glioblastoma.
Very good. You see it in glioblastoma. This type of glomerular proliferation is specific for glioblastoma. You can see that even within this proliferation, mitotic activity can be seen. You see that? They're very florid microvascular proliferation. And then now what has happened?
Necrosis.
Ma'am, here the large area of necrosis is present.
Very good. This is called confluent necrosis. Along with that, what has happened to this is another vascular change. One was sprouting angiogenesis. Another one was microvascular proliferation. Now the third vascular change. What is that? These are very thick sclerosed and thrombosed blood vessels. This is thrombosed and recanalized. You see that? There is recanalization happening. So actually, even the clinician will tell us while operating that there were huge thrombosed veins on the surface of the tumor. He himself will tell us that. So this is another vascular change, and because of this, you see this confluent necrosis, large areas of necrosis, which we call as confluent necrosis. So we saw one sprouting angiogenesis, we saw microvascular proliferation, we saw sclerosed thrombosed vessels, and we saw confluent necrosis. So now we will see another type of necrosis.
These are, ma'am, serpentine necrosis, serpentine pericytic necrosis, where the tumor cell mark the borders.
Very good, 100%, 100 marks for you. Very good. These are all called as palisading necrosis. See, palisading necrosis can be seen in other high-grade tumors also. Even in grade 3 oligo, sometimes you can see palisading necrosis. But this type of palisading, multiple palisades like this, is very specific to glioblastoma. Okay. So this is palisading necrosis. Yes, Sauvik, what is your preliminary diagnosis?
Glioblastoma NOS WHO grade 4.
My goodness, you're too good. Too good.
Histologic grade 4. Histologic grade
Very good. Histologic grade 4 because we are giving an NOS diagnosis. Very good. Full marks for you. What do we want to do, Sauvik?
IC markers.
Marker or markers?
Markers.
ATRX, we can do ATRX marker. And IDH marker we can do. IDH1. And ma'am,
I have done this. Tell me what is this and what does it show and what is its utility?
Ma'am, it is BRF PV600E mutation.
There you're going, man. You're going, man. Really, from where to where you're jumping. You were doing so well till now. Suddenly you went in some other direction. BRF
Negative IDH1.
IDH1, negative IDH1.
Yeah, it is negative for IDH1 R132H, isn't it?
Yes, sir.
What am I going to call this now? What is your diagnosis? What is the molecular test? Let us not go for any prognostic marker, predictive marker. That we will not discuss that. So this is glioblastoma, IDH wild type, CNS WHO grade 4. Now we know that glioblastoma is only IDH wild type. There is no mutant anymore. Mutant became astrocytoma, IDH mutant grade 4. Okay, CNS WHO grade 4. So glioblastoma is only IDH wild type. We are calling this as IDH wild type with IHC itself because the patient is age 60 years and IHC is negative. The reason is, as per WHO recommendation, any patient equal to or above the age of 55 years, if IHC is negative for IDH1 R132H, it's more than sufficient to call it as glioblastoma IDH wild type. Okay. Because the frequency of the other mutations after the age of 55 years is almost nil. You don't get the other mutations. But if patient is below 55 years and IDH1 R132H is negative by IHC, then sequencing for other IDH mutations will be required. That you can take a decision based on ATRX status, P53 status, all that you can decide and then do a IDH sequencing. But if the patient is this patient was 60 years old and IDH1 R132H was negative, so conveniently we can call it as glioblastoma IDH wild type, CNS WHO grade 4. Is that clear? Did you understand that?
Yes.
So in the previous classification, we had these are the two types of glioblastoma, IDH wild type and we had the IDH mutant. And at that time, the essential criteria was that it's a high-grade astrocytic glioma with nuclear atypia, cellular pleomorphism, and increased mitosis with microvascular proliferation and or necrosis. That was the definition for glioblastoma at that time in 2016 classification. And that could be mutant or wild type. But now we know that it is only wild type. There is no mutant at all. So the essential criteria is that it's an IDH or a H3. Histone also will be wild type with one or more of these histological and genetic parameters. So we don't have to have only if we have these one of these two features or both these two looking like this, then sure shot it is glioblastoma. But it may look like a grade 2 or grade 3 tumor histologically. If it harbors any of these molecular alterations, note it down for those who don't know: EGFR amplification, third promoter mutation, gain of chromosome 7, and loss of chromosome 10 copy numbers. If any one of them or more are positive, even then it is a glioblastoma, IDH wild type. So IDH wild type glioblastoma, there are 5 criteria. You can have one or more of any of these criteria. Okay, and the first two criteria are generally referred to as histological glioblastoma, and the latter two are referred to as molecular glioblastoma. But both are glioblastoma IDH wild type, and they have the same behavior. So just like astrocytoma IDH mutant, where you had the CDKN2AB playing such an important role for grading, here also you have these 3 molecular markers which are very important for grading. Okay, did you understand that? So it is not just histology, but I did not show a case like this, but I'm just telling you that even if it shows grade 2, grade 3 morphology, but it has these features, any one of these features, then you can call it as a glioblastoma IDH wild type. So I won't go into the prognostic marker, but I will just go into the subtypes of glioblastoma. Now, Souvik, you'll be very interested. There are 3 subtypes of glioblastoma. Earlier we used to call it as variants, histological variants, but now they're called as subtypes. One is giant cell glioblastoma, other is gliosarcoma, and epithelioid glioblastoma. They are the subtypes. Giant cell glioblastoma, these are usually more superficially located tumors, and they're little more circumscribed tumors. And histologically, they have this bizarre multinucleated tumor giant cells, monstrocellular. That's what we call it. Okay, they're GFAP positive, but they'll be diffusely strongly p53 positive. They're IDH wild type tumors. That is giant cell glioblastoma. Gliosarcoma, this is a biphasic tumor. It has sarcomatous element, it has glial element. Sarcomatous elements will be highlighted by this reticulin stain because sarcoma are mesenchymal elements where the stroma will be mesenchymal, and that is where reticulin will be positive, and glial element will be negative for reticulin. Reticulin is a very important stain in CNS tumors. You use it for many, for PXA, for gliosarcomas, for medulloblastomas. It's very, very important stain. Simple stain, but it helps a lot. Then we use diagnostic markers, GFAP. If you use GFAP, it is positive in the glial elements, but not the sarcomatous elements. Then you use a mesenchymal marker that is vimentin. But mind you, that vimentin is also a marker for astrocytes. It's not just for the mesenchymal cells. So vimentin will be positive for both of them. And there will be evidence of malignant features both in the glial as well as in the mesenchymal elements. So that is a gliosarcoma. And the third one is epithelioid glioblastoma. This occurs in younger individuals, older children or young adults. Very aggressive tumor. It has these cells which have this epithelioid or rhabdoid morphology. Very, round to polyhedral cells, abundant eosinophilic glassy cytoplasm, binucleate or uninucleate, nucleus pushed to periphery, high mitosis, and angiocentric pattern of arrangement. All these are very typical. Microvascular proliferation and or necrosis will be there. And these are the tumors, they're IDH wild type. These are the tumors that, not all, about 50% of them will harbor this BRAF V600D mutation. Okay, you were trained, no, BRAF V600D? This is one of the tumors that harbors the BRAF V600D mutation, and they're variably GFAP positive. So did you understand that? Very good. You've done very well, Souvik. I'm very happy that you were able to explain. But I just want you to remember that glioblastoma. See, glioblastoma earlier used to be called as glioblastoma multiforme. That multiforme word has been removed, but it's a very good word, multiforme. It's such a variegated tumor, clinically, radiologically, histologically. You'll see so much of variegation. You'll see that the cells will be spindle shaped, pleomorphic, giant cells, all types of sarcomatous, primitive neuroectodermal, all types of cells will be there in glioblastoma. But they removed the term multiforme. But they are IDH wild type tumors. So this table is only to revise what we have learned. So among adult type diffuse gliomas, there are 3 tumor types. The first one is astrocytoma IDH mutant. These are graded as CNS grade 2, 3, and 4. That has replaced the previous terminologies: diffuse astrocytoma, anaplastic astrocytoma, IDH mutant glioblastoma, which are no longer used. There is grading within this tumor type. That's why there is grade 2, 3, 4. And we use a combined histological and molecular grading for this tumor. Both histology and molecular will be taken into consideration. And astrocytoma IDH wild type is eliminated. Oligodendroglioma IDH mutant 1p19q co-deleted. These are the mandatory molecular markers to make the diagnosis. It's graded as 2 and 3. The current diagnostic and grading criteria remains unchanged. It is the same as in the WHO 2016 classification. For grade 3 tumors, we don't use the term anaplastic oligo. We just say that it's grade 3. And the term oligoastrocytoma is deleted. You can use it as an NOS terminology. And glioblastoma is only IDH wild type. It is seen as WHO grade 4. Note that all of them are in Arabic numerals. And the term glioblastoma IDH mutant is eliminated. And a combined histological and molecular grading is also introduced to glioblastoma IDH wild type. Apart from histology, you take these 3 molecular markers, EGFR amplification, third promoter mutation, gain of chromosome 7, and loss of chromosome 10 copy number changes into consideration for grading glioblastoma IDH wild type. Is that clear? Any questions? Any questions on glioblastoma? Did you understand glioblastoma? Histological glioblastoma and molecular glioblastoma. Okay. So it's almost 9:10. Sumit, can I show another case or shall we stop?
Of course, you can. Please go ahead.
Really?
There are students, there are still, if you look at the chat box, there are still 210 to 208, delegates here in the room. So they will kill me before they do anything else if I tell you to stop.
So whom will
maybe we can do these 2 cases a little more quickly. That's all I request.
Okay, so maybe I'll only describe these cases. We have the next case is a 25-year-old male with complaints of seizures for 3 years. That is long duration. Weakness of the right upper and lower limb. This is also of long duration. There is no features of raised intracranial pressure, no headache or vomiting, and the patient had left-sided hemiparesis. So there is some sort of a right-sided lesion. And Kajri, can you describe this a little bit more quickly? Yeah, I'll approve this. Yeah.
Please unmute yourself.
Kajri?
Yeah, sorry, ma'am. So what we're seeing is these three sets of images. The central one is the T2, which we look at. So first we're seeing that this is obviously a right-sided lesion, and the location of the lesion is in the right temporal lobe. Now, temporal lobe harbors a very distinct type of tumors, and these present with epilepsies, and therefore temporal lobe epilepsy is a very common presentation of these tumors. Now, in contradistinction to the previous tumors where we are seeing that these tumors were having ill-defined margin, if we see at this tumor is having a very well-defined margin. There is no significant perilesional edema, and it has two components. So if we see on T2, this has one component which is a little bit intermediate or a little bit solid one, and there's a cystic component which is more posteriorly located. So what we're seeing again in the flare image, this cystic component is showing completely inverted. So it's following the CSF signal, or it is completely inverting, again signifying that it is a cystic component and this is the solid component. When we go to the post-contrast study, we are seeing that the solid component is showing intense post-contrast enhancement. So basically, there is a terminology in radiology where we say that it is a tumor which has a cyst with a mural nodule, and this mural nodule is a little bit eccentrically located. It is more anteriorly located, right? So we are seeing what is basically a circumscribed lesion which has a cyst with a mural nodule morphology and no significant perilesional edema, which is present in the right temporal lobe. And therefore, my differentials radiologically will be a circumscribed astrocytoma, whether it's a pilocytic astrocytoma or circumscribed, or it could be a pleomorphic xanthoastrocytoma or a glioneuronal tumor like a ganglioma. So these will be my radiological differentials.
Excellent, excellent. So cyst with a mural nodule, please remember temporal cortex, and she has very nicely described with 3 differential diagnoses. So
just one point, Vani.
Yes, yes.
You know, the T1 contrast is very well seen in the medial near the sylvian fascia, but if you look at the T2 and the flares, there seems to be at the posterior medial aspect of the enhancing nodule some other abnormality. Is that part of the?
Yes. So basically, sir, this part. So yeah, there is a second component. So if we look at the flare image, we are seeing this dumbbell kind of configuration, whereas only one part of the tumor is enhancing brilliantly. So yeah, the entire solid component is not enhancing. And this is a little bit more intermediate on T2. So there may be a little bit of heterogeneity within the tumor also. So then in that case, again, I would again have to look at a gradient image to see whether there is any calcification present within this tumor. And then I would think more in terms of a PXA and a ganglioma rather than a pilocytic astrocytoma.
Exactly crossed my mind too. You could also do the flare, the diffusion rated imaging to see whether there's an intersection. It looks to be a pleomorphic xanthoastrocytoma more than a prostate.
We have some very brilliant clinicians over here. Very difficult for me to. Okay, let me share this again. Yeah. So here we go. So Nagma, do you want to quickly describe, or do you want me to describe?
Nagma, try. Nagma,
Try.
Yeah.
Try. So you can see a tumor. See, this has come right up to the surface. Actually, this is the leptomeninges. This is the leptomeninges. A tumor has come up. It is very superficially placed. Whatever was removed was superficially placed. And let me tell you that it was quite firm in consistency. And here, what can you make out? Sorry? Okay, don't bother about it. I will describe because we're running short of time. You remember Dr. Kajri said that she felt it was more a circumscribed tumor than a diffuse tumor. Here, what you can see is a nice pushing margin. This is the tumor and this is the brain parenchyma. There is some calcification. There is a pushing margin over here. See, in the brain, no brain tumor is encapsulated, okay, within the parenchyma. When we say a circumscribed tumor, what we mean is histologically it will have some sort of a pushing margin. And the tumor was very firm because you can see that this is a reticulin stain. Again, a very useful stain. And the tumor shows dense reticulin fibers in the background. And you can see now so beautifully it is circumscribed and it is really having a good pushing margin from the rest of the parenchyma where only the blood vessels are reticulin positive. But here the tumor has intrinsic positivity with reticulin. Now you describe. Now this is easy. You can describe.
There are large multinucleated xanthomatous cells.
Very good. Very good. What is this?
There is intracellular accumulations of lipids in
some of these cells. Yes, it appears lipid. It is just sort of, it is pale and xanthomatous. Yes, I agree. What is this one? Just give me these features. That's more than enough. What is this?
This is
Vascular lymphocytic coughing.
Very good. Very good. Who said that? Ivani?
Yes, ma'am.
Yes, what is this? Perivascular lymphocytic infiltrates, tumor infiltrating lymphocytes, pleomorphic cells, large cells, some of them have binucleation. And then what is this? This you must tell me. Nagma.
eosinophilic.
Eosinophilic granular body. This is a very typical eosinophilic granular body. So this is eosinophilic granular body. Now you can see the spindle-shaped astrocytes, numerous eosinophilic granular bodies, and then these what you called as lipidized cells. You see that? They're all pale and lipidized, these cells, and prominent perivascular tumor infiltrating lymphocytes. Is there mitosis?
Yes.
No.
Yes, ma'am.
No mitosis. They're only nuclear. It's pleomorphic, very pleomorphic, but there is no mitotic activity. Okay. And at certain places, you can see these epithelioid-like cells. What we saw in epithelioid GBM, you can see some accumulation of these epithelioid cells, but they don't have any mitotic activity. So we have done diagnostic IHCs. GFAP is positive or negative?
It's positive.
Positive. It's variably positive. Most of the tumor cells and their processes are positive. These pale lipidized cells, they don't take up GFAP, so we call it positive. We did synaptophysin because some of them had a ganglioid-like appearance. So we were, like Dr. Kajri said, ganglioma is a differential diagnosis, but synaptophysin is negative. P53 is negative, so we have ruled out some giant cell glabs. All those things we have ruled out. I have shown an area which is slightly higher, but the MIP labeling was very low in this case. It was less than 5%. Then I've done this particular stain. Any one of you can tell me what the stain. What did you diagnose with all this?
BRAF PV 600E. Yes, ma'am, Siddhi.
Very good, Siddhi. Full marks for you. So this is the BRAF V600E. So this has come strongly positive. So now, Siddhi, you tell me what is your diagnosis, and you have a differential diagnosis.
This is pleomorphic xanthoastrocytoma, and the differential diagnosis is ganglioma, epithelioid glioblastoma, and high-grade astrocytoma with pyeloid features.
Wow, she's gone through WHO CNS very nicely. So yes, the diagnosis is pleomorphic xanthoastrocytoma. I've already given a CNS WHO grade. Why did I give a CNS WHO grade? Because the essential diagnostic criteria does not require molecular markers for this particular tumor. So pleomorphic xanthoastrocytoma, as Dr. Rakesh and Dr. Kajri had already made the diagnosis, and they're absolutely correct. It's a circumscribed astrocytic glioma. We have 6 tumor types in this group of circumscribed astrocytic glioma. Most of them occur in the pediatric age group, but some of them occur in the young adults also, and one of them is pleomorphic xanthoastrocytoma. What is pleomorphic xanthoastrocytoma? As the name indicates, it's a pleomorphic tumor which has xanthomatous cells, as you saw. It is astrocytic because we saw GFAP positivity. Usually occurs in children or the young adults. Most often temporal cortex superficially placed tumor. A cyst with mural nodule is the characteristic feature. Patients present with long-standing seizures. There are two grades, CNS WHO grade 2 and 3. The grade 3 tumor was earlier called as anaplastic PXA, but we don't call that now. We just say CNS WHO grade 3. Now, these tumors characteristically harbor the BRAF V600E mutation, but that is seen in only 70 to 80% in grade 2 and about 50 to 60% in grade 3 tumors. And they also simultaneously have the CDKN2AB homozygous deletion, which we don't have to demonstrate because the essential diagnostic criteria for PXA is only histological. It's an astrocytoma with pleomorphic tumor cells, including large multinucleated cells, spindle-shaped cells, xanthomatous cells, and eosinophilic gland bodies. And all others, including reticulin, BRAF, CDKN2AB, DNA methylation profile, everything is a desirable criteria. And a grade 3 tumor has high mitosis. Usually, it will have more than 5 mitosis in 10 hyperphases with or without necrosis. So that will be a grade 3 tumor. And as you rightly said, if you look at the differential diagnosis, the first differential diagnosis is ganglioglioma, which is a grade 1 tumor. Most features of PXA will be like ganglioglioma only. But what we see in ganglioglioma, that is, we'll see tumor infiltrating lymphocytes, we see pleomorphic cells, we can see eosinophilic gland bodies. But in ganglioglioma, you have this clustering of neoplastic ganglion cells, which is not there in PXA. And the clustering of neoplastic ganglion cells can be highlighted by using stains such as chromogranin or synaptophysin. So you may have an occasional cell that is synaptophysin positive in PXA, but this clustering is very, very typical of gangliogliomas. CD34 is positive in both of the tumors. But in PXA, it's usually the tumor cells that are positive, and in ganglioglioma, it is the adjacent ramified neuritic processes that are positive. So these are some soft histological IHC signs that you have to take into consideration. Now you may ask me the question, why should I differentiate ganglioglioma from PXA? PXA is a grade 2 or a grade 3 tumor, and ganglioglioma is very benign. It's a grade 1 tumor. Epithelioid GBM is a close differential diagnosis for grade 3 tumors, particularly when they have those epithelioid cells. They're known as epithelioid PXAs. You can have those epithelioid cells even in PXA. It becomes very difficult to differentiate because all markers will be the same. Even BRAF V600E positivity is seen in both. The only few points that we take into consideration is that in epithelioid GBM, there will be areas of necrosis, microvascular proliferation, which may or may not be there in grade 3 PXA. And PXAs, grade 3 will have lower grade areas and eosinophilic gland bodies. You must identify that. It's a regressive change. You have to identify that to call it as a PXA, which will not be there in epithelioid GBM. It's very difficult sometimes to differentiate the two, and many pathologists have made this mistake. If you look at the prognosis of PXA, although it is very pleomorphic, it behaves in a less malignant manner, but frequently it recurs. It can even progress to grade 3 tumors, and therefore complete resection is always beneficial. And adjuvant therapy is indicated, including targeted therapy with BRAF inhibitors, particularly in partially resected and in grade 3 cases. Okay, that's about pleomorphic xanthoastrocytoma, which is a circumscribed astrocytic glioma. Did you understand that? Any questions? Rakesh, any comments?
I mean, just a couple of comments. Beautifully shown case. PXA, I just want to highlight over a period of time, we used to lump them in these low-grade tumors, the PXAs, DNATs, pilostics, maybe 20, 25 years ago when we were students. But obviously, we realized PXA is not a simple tumor, so you have to keep a very close watch, even in grade 2 tumors. And grade 3 tumors obviously are much more aggressive. They're not as bad as GBM, of course, but the long-term survival is only 35 to 40%. Grade 2, of course, have 80 to 90% survival if you do it well. One of the points to differentiate grade 3 PXA and epithelioid GBM on MRI is also if they have bleeding. Many times, epithelioid GBMs, they present with bleed, and it's the cortical location. And many times in our clinic, we look at the MR and we think whether it could be an epithelioid GBM. And they need not have the cystic and only the nodule. They can be solid, also epithelioid GBM as compared to PXAs. And finally, epithelioid GBM, they have two variants. One is very early aggressive behavior with extensive leptomeningeal metastasis. But some of the epithelioid GBMs, in fact, we have analyzed the data and we are submitting for manuscript for the publication, that some of them do very, very well. I have long-term epithelioid GBMs for 5-7 years, and we have gone back whether they could be PXA, whether they have V600 mutation. And you have to see the reticulin is a very important stain, what you rightly said. I always ask for reticulin because that can differentiate a lot of tumors. And if you have a bleed on them, they tend to be epithelioid GBM, and we use radiation, sometimes targeted therapies for many patients, what is called MEK inhibitors, a dual combination of MEK inhibitor as well as the BRAF inhibitor, and they do very well. Finally, last point, all of them may not show V600 mutation. There can be other variants of also V600. Occasionally, there's a strong clinical suspicion. We recently had one patient, strong suspicion, twice surgery done from Calcutta. Eventually, it was V600R when we did run NGS. So you have to have that clinical and pathological threshold to subject to the subsequent therapy. So a couple of slides of these comments might help.
Very, very useful. It's really a few points that take-home message I think is really good, particularly on MRI, how to differentiate, because many pathologists have this problem between epithelioid GBM, and I keep getting referrals that please tell us whether this is a grade 3 PXA or whether this is epithelioid GBM. So there's a lot of problem with that. Thank you so much for that. I'll just show you one last case. We'll go very fast on this case.
And Vani, just to interrupt you, there are still 198 delegates, and I would like to tell them after this last case of Vani, Kajri will do 5 minutes quick 6-7 scans. So please don't go away and listen to Kajri, Dr. Kajri for the
Sure.
I know that this guy, Jalali must be hungry. Jalali dinner can wait.
No, the presentation is very delicious, so we are enjoying it. It's a feast.
So I'll ask maybe Akshita, can you come back to this case? There's a 21-year-old lady who came to our epilepsy clinic. Actually, she complained of she had complex partial seizures for about 10 years. She was on anti-epileptics. She did not have any relief from her seizures, but she did not have any raised intracranial pressure. There were no neurological deficits, and she was diagnosed as drug-resistant epilepsy. So she's come to our clinic, to our epilepsy clinic, for evaluation. And these are her scans. Kajri, if you can just quickly describe this, I'll approve your annotation. Yeah.
So what we are seeing is these 4 sets of images. Again, we look at the T2. What we are seeing is basically this lesion. If we see and compare it with the other lesions, again, this is a very well circumscribed lesion. It is located in the cortex, and basically it is located at the temporal lobe. So it's a temporal lobe cortex lesion, and there is no perilesional edema. So it's a very homogeneous lesion. It's a very bright lesion on a T2-weighted image. And one very important feature is, if you can see this, there's a scalloping of the overlying cortical bone, which signifies that it's a long-standing lesion. So that's a benign, long-standing lesion which is present in the temporal lobe cortex. So if you look at the T1, it's hypointense on T1. Obviously, we have to look at the contrast, and I'm not expecting much of a contrast enhancement in this case. There is no diffusion restriction. There is no blooming or no calcification in this. So a cortex-based, this finger-like lesion, which is having scalloping of the overlying bone, I would put my diagnosis as a DNET in this particular case, the right temporal lobe.
Okay.
I agree with that. No, it's fine. I think it is DNET because of the scalloping. And mind you, she present at the age of 11. She's 21 now. 10 years ago history. And if you have to stretch your imagination, sometimes Hamartomas, you have to always think of occasionally, although they have to be other sequela. And oligos sometimes pathologically can be confused with the DNET, and the age is important. One final comment, Kajri will bear with me as a clinician. Sometimes they may ask the pathologist, no, but I saw the edema. Sometimes these patients present with a seizure and immediately an MRI is done, and you have a typical periictal edema.
Yes.
But it is a long-standing process. They may not carry the old scans with them, or they may not tell you the history because they're in a post-ictal confusional state. And sometimes it looks like a high grade actually because of the so much edema, which is post-ictal. And they will say, no, it is high grade, you tell me. And the pathologist, of course, says it's DNET or a low grade. It's a small, subtle clinical point.
Yes, and I would also like to add that if the patient is presenting just after an ictus and there is edema, we can also expect in a diffusion weighted imaging to see those ictal post-ictal changes, which we'll see as diffusion restriction along that particular cortex. So that would also be an indicating finding.
Okay, thank you so much. And again, it's quite a simple case, but a very nice case. You can have a look at the histology, which is very interesting. So this patient came as a part of our epilepsy clinic program, and the lesion was resected en bloc. Usually we don't get samples like this; it will be very fragmented for the pathologist. But here you can beautifully see it's an en bloc resection of the tissue. And what you can see here, this is the gray matter, and what you can see here is the white matter. And in the gray matter, I hope you can see all these multiple pale nodules, cortical nodules. They're in the gray matter. White matter is unaffected; it is spared. So most of the diffuse gliomas, they arise in the white matter and then they spread to the gray matter. But here you can see that it is cortically based. It is in the gray matter and the white matter is spared. And this is one large pale nodule in the cortex. And this is the adjacent gray matter. This is the portion of the white matter. And this is that circumscribed nodule, pale nodule in the gray matter. And higher magnification shows you three important things. You can see these spaces. Can anybody, Akshita, can you tell me what these spaces are? Microcystic spaces. And what are they lined by? Oligodendrocyte-like cells. And what are these?
These are
Floating neurons. So this is the higher magnification. You can see three important features. Please observe them in the gray matter. Multiple pale nodules. The nodules are composed of these microcystic spaces lined by small round cells. They're oligodendrocyte-like, but they're not true oligodendrocytic cells. And there are these floating neurons. There is no connection at all. Look at the neurons. They seem to be floating in this in the microcystic space. And this is the typical glioneuronal element. And these microcystic spaces can have a myxoid-like material. You saw this. It has this myxoid-like material within the microcystic space. We can sometimes, if it is not very clear, you can highlight that by a special stain. I've used one special stain here. Can somebody tell me what special stain I've used for this myxoid matrix? Which one? Very good, 100 marks. Alcian blue. I've used Alcian blue, and with Alcian blue, you can see how beautifully these microcystic spaces with the myxoid material is highlighted. Can you name one more CNS tumor where the stain is very useful? See, Dr. Rakesh said reticulin is very useful. He likes reticulin stain very much for so many tumors. Another stain I like a lot is Alcian blue. It's very good for these tumors. This is a DNET. There is no difficulty in diagnosis. But you can also use it for another tumor. Can you tell me one example where you can use Alcian blue?
Myxopapillary ependymoma.
Who said that?
Yes, ma'am.
Siddhi, you're too good. Very good. You use it for myxopapillary ependymoma because not all myxopapillary ependymomas on histology will show that myxoid core in the papillae. You cannot identify in all tumors. When you can identify histologically, it's good. But if you can't identify, please use Alcian blue. Alcian blue helps a lot. I keep telling my residents, please use Alcian blue for these tumors. Okay? So Alcian blue is positive. So how does this GFAP stain this? Are the tumor cells positive or negative? What is staining? Negative.
Our astrocytic cells are positive.
These are the stellate astrocytes. They're the reactive cells. You see this reactive astrocytes? Reactive astrocytes have many processes like this, like a spider. Looks like a spider. So they're known as stellate or reactive astrocytes. Tumor cells are negative. And the processes that were lining these microcystic spaces, these are the floating neurons. The processes are all stained by this neurofilament protein and synaptophysin. That's why it is glioneuronal. There is some glial element, there is some neuronal element. NUN is a neuronal nuclear stain. It is meant for entrapped nuclei, dysmorphic nuclei, but not the neoplastic ganglion cells. You don't use it for ganglioglioma. Here you can see that some of the floating neurons are NUN positive, so you know that they are floating neurons. And only one cell is labeled by maybe. It is very, very benign. So what is our diagnosis? Differential diagnosis. Any molecular test to make the diagnosis? We don't need any of that. This is a dysembryoplastic neuroepithelial tumor called as DNET. CNS, I've given the full diagnosis. CNS WHO grade 1. Now, what is DNETs? DNETs are tumors that occur in children or young adults presenting with refractory epilepsy. They have the pathognomonic glioneuronal element, which comprises the microcystic spaces, oligodendrocyte-like cells. You can use OLIG too. They will be positive in those OLCs. I didn't show you one stain, but they'll be positive. And floating neurons. Now, the characteristic alteration is the FGFR1 alteration, different types of alterations of FGFR1 gene, seen in 40 to 80%, and about 50% also show BRAF V600E mutation in DNETs. But you don't have to have any of those molecular alterations to make a diagnosis. Essential criteria is only histological, cortical glioneuronal tumor with the presence of specific glioneuronal element. Only if it is unresolved, you have to use the genetic alterations, but otherwise you don't need that. There are three histologically recognized patterns in DNET. One is the simple DNET with this unique glioneuronal element that all of us saw. One is called as complex DNET. Now, these DNETs will have a glioneuronal element. Along with that, there'll be some glial nodules that can resemble pilocytic astrocytoma, oligodendroglioma. There can be calcification. It becomes difficult to diagnose. And then you may require molecular markers. Diffuse or non-specific forms that can lack a glioneuronal element. It can have a lot of diffuse, non-specific histology. They've been termed, some people call it diffuse oligo, some people call it DNET-like tumor, some people call it as glioneuronal tumor, NOS. So sometimes when it has this diffuse, non-specific histology, it becomes difficult for a pathologist to diagnose. We may have to use the molecular alterations. Close differential diagnosis, as Dr. Rakesh already mentioned, is oligodendroglioma. Here, of course, the tumor the patient started her symptoms when she was only 11 years old. So oligos don't occur in the children, but sometimes it can be seen in older, in young adults also. So oligodendroglioma is one differential diagnosis, but here you have to show IDH mutation 1p19q deletion. There is a new glioneuronal tumor type described in WHO CNS5 called myxoid glioneuronal tumor, which is like a DNET-like tumor, but occurs in the deeper structures, like in septum pellucidum, corpus callosum, periventricular white matter, and that will have GFAP and SOX10 positivity. And of course, the other tumors like the plenty, MVNT, don't bother about that. They are the differential diagnosis. So DNETs are all very benign tumor. Here, the surgery is basically performed for relief from seizures. It is not for oncological purposes because malignant transformation actually does not occur in these tumors. There are anecdotal reports where there have been malignant transformation of DNETs. So finally, this is how the glioneuronal tumors are classified in WHO CNS5. Compare the 2016 with the 2021 classification. What is in red fonts are the histological features, green fonts are the new tumor types, and what has been strike through are what is deleted in WHO CNS5. So the glioneuronal tumors that are composed predominantly of ganglion cells are ganglioblastoma, gangliocytoma. There is no anaplastic ganglioblastoma anymore. Desmoplastic infantile ganglioblastoma or astrocytoma. Multinodular and vacuolating neuronal tumor, which is a newly described tumor, and dysplastic cerebellar gangliocytoma known as Lermite-Diplus disease. All of them are characterized mainly by ganglion cells. But there are tumors that are characterized by neurocytic cells, like central neurocytoma, extraventricular neurocytoma, cerebellar liponeurocytoma, papillary and rosette-forming glioneuronal tumor, and this diffuse leptomeningeal glioneuronal tumor with glioneuronal tumor or DLGNT. These are all composed of neurocytes. And there are tumors composed of oligodendrocyte-like cells, predominantly, like our tumor, that is DNET, myxoid glioneuronal tumor, and this new tumor type known as DG-ONC, which you don't have to bother. And paraganglioma has been removed from this group of tumors. But what is good for us pathologists is that there are 14 tumor types in this group of glioneuronal tumors. 11 of them can be diagnosed only with histology and with required IHCs, diagnostic IHC markers. You don't require any molecular you don't need to demonstrate any molecular alterations. Only for 2, that is papillary glioneuronal tumor and DLGNT, you have to show the molecular alteration. And there is one newly described tumor type which is provisional, that is known as DG-ONC, which is defined by methylation profiling. So don't bother about that. But do remember that 11 of them can be diagnosed only by histology. Okay, and you use the right IHC markers or the special states. So you're absolutely correct. The diagnosis here is this embryoplastic neuroepithelial tumor. Rakesh, comments, Rakesh?
It's pretty well covered. Surgery is the treatment of choice because not only it cures, but epilepsy, which can be very, very difficult in these children and young adults. And sometimes patients and families are reluctant when they tell them it's a very benign thing. So oncologically, they will not progress, but epilepsy impairs their quality of life and their education. So you have to motivate them to undergo surgery, but otherwise they're eminently curable. I wanted your one comment on this relationship with hematoma, because some people say DNET is not really a tumor, it's basically a hematoma, and sometimes it can be confused actually with hematoma.
What happened was when it was first described, I don't know if you remember, it was first described in the year 1993 by Catherine Thomas-Dupont. Unfortunately, we lost her, but she's from St. Anne and Mayo Clinic in Paris, and she was the one who first described DNET. And till such a time, these tumors were called as hematomas only. And she first said that no, this is not a hematoma, it is a tumor, and it is a very low-grade tumor, and it is a glioneuronal tumor. And subsequently, it was included in the classification. So tumor-like was what was thought of. But as I told you that if the tumor has this complex DNET kind of a pattern, it may have a small glioneuronal component, but the rest of it can be just like a hematoma. You can see glioneuronal nodules, hematomatous nodules inside that. And the other thing is that DNETs can coexist with focal cortical dysplasia. So FCD type 3A3B will have this tumors associated with the focal cortical dysplasia, and that is also a hematomatous. So it comes under FCD classification also. So that is the importance, and you're right. It was thought of for a long time as hematoma, and even now in FCD it can coexist with focal cortical dysplasia.
I mean, the point of complex DNET also is a little bit of a debatable point. Although it is recognized as an entity, to actually diagnose it is not easy. You have to demonstrate a very clear-cut neoplastic gliopathology, which is actually extremely rare. Some people have tried to publish also complex DNET. It's not easy to get published a complex DNET case because you have to convince the reviewer whether there is any complexity involved in it. And if there is, those are the cases sometimes who may recur and progress later on. Okay. A small, tiny percentage of these cases because they are driven by, obviously, they have a different kind of profile and glial. And other tumors, we don't have time. They're all interesting cases. For example, the RGNT, the Lermite-Diplus.
Yeah, I will take one session on glioneuronal tumor separately, but you're absolutely right. Thank you so much for that. I think he has really given us some pearls of wisdom, I should say. And I think I'll stop at this and just want to tell the students that very recently we have published this textbook. This is the second edition of Essentials in Diagnostic Surgical Neuropathology, where a lot of tumors and even non-neoplastic lesions are covered, and it is it is very concise, and everything is described point-wise and very easy to understand. So for those who are interested and who want to quickly go through the tumors and you don't have enough time for WHO CNS5, you can go through this book, which has all the information in a point-wise and a concise manner. So with that, I think I'm going to stop now, and thank you all for your very, very patient hearing.
I think Kajri, thank you, Vani, very much. I think Kajri will take 5 minutes. In the meantime, if there are a couple of questions at the end of Kajri's presentation, we can take them. Kajri, over to you.
Yes, sir. Thank you so much, ma'am. I hate to go after you because that was such a brilliant session. And I don't know whether I'll be able to do any justice to this after your brilliant session, but still I'll try, ma'am. So basically the idea of So the idea of this presentation is that I just want the MD pathology residents also to have a little bit of idea of the radiology, because obviously when a patient presents with a symptom of a clinical features which is suspicious of a brain lesion or a tumor, then we always do an MRI brain. So these are the basic sequences which we acquire in all the tumors of brain, and other than that, there are some specialized sequences which we acquire as and when needed. So just to identify, so first this is an axial plane, this is a sagittal plane, and there is a coronal plane. There are multiple planes in which these images are acquired. And how do we identify these sequences? The first and the basic sequence is a T2-weighted sequence, T2-weighted image, in which how do we identify that? This is the gray matter. It appears, the gray matter appears a little bit brighter, and the white matter appears a bit darker. So the gray is bright, and the gray is white, and the white is gray. So basically the opposite of what we see in T1. T1 is the basic sequence in which the gray is gray and the white is white. Opposite of that is seen in T2. And in T2, we see these ventricles. These have the CSF spaces, so these appear bright. So we see a T2, a T1. We also take something which is called as flare, which is just similar to T2, but the CSF space is suppressed, so this appears black. This sequence, that's a gradient or an SWI sequence, is important because it shows calcifications and microbleeds, which help us diagnose various types of. So in terms of gliomas, if you're looking for an oligodendroglioma, or if you're looking at a GBM where we need to see bleed, and oligodendroglioma where we need to see a calcification, then that can help us. A diffusion image shows, in terms of tumor specifically talking, it can actually show us the cellularity of the tumor. So what we mean by diffusion restriction is that the cellularity of the tumor is high. So in that case, this will appear bright in this DWI image, and it should correspondingly appear darker in an ADC image. So these two images go hand in hand. And finally, is a post-contrast image, which is on a T1 weighted image. We give a contrast, which is a gadolinium-based contrast agent, and where we can see that whether the tumor is enhancing or not, and that gives a basic idea. about the grade of the tumor. So first thing is how to differentiate between a circumscribed and diffuse lesion. So here we can see this is a lesion which is present in the right frontal lobe. The margins of the lesion are not well delineated. So this is a diffuse lesion. Whereas in this case, the margin of the lesion is so nicely appreciated. It's very well circumscribed tumor. So this is how you differentiate between a diffuse and a circumscribed tumor. So whenever we're looking at an image, first we look at what is the location of the tumors, whether it's in deep or it's superficial tumor, it's located in the cortex or the white matter or periventricular region, and what is the character of the tumor. So whether it is a circumscribed tumor or it's a diffuse tumor. So in general, the basic character of all the tumors are they're a little bit hyperintense or they're bright on T2 image. So the next thing is so next thing is the very specific imaging feature which we talked about in our first case. That is an IDH mutant 1p19q non-codelated tumor which shows a T2 flare mismatch. So this is a hyperintense on T2 and it shows inversion in flare. So this is a clear idea that this is 100% specific and almost 40% sensitive for an IDH mutant 1p19q codelated tumor. So if you see this in your MRI, you can be sure that your pathological diagnosis is going to be this. So in contradistinction to this one, where we don't see that T2 flare mismatch, this is not this kind of a tumor. So how do we differentiate a lower grade glioma from a higher grade glioma or an astrocytoma? So in the lower grade tumors are generally homogeneous like this. They're very homogeneous. They're generally hyperintense, so they're bright on T2. They don't show any diffusion restriction, so they're not bright on DWI and they're not dark on ADC. There is no enhancement or there is intense post-contrast enhancement or homogeneous enhancement as we see in pilocytic astrocytomas. There are no signs of neoangiogenesis or no microbleeds as we see in the SWI or the gradient weighted images, and there are no necrosis, so therefore there is no enhancement. It's a very homogeneous tumor. And looking at this perfusion imaging also helps us. Basically, perfusion tells us that what is the amount of blood flow to that particular part of the tumor. So lower grade tumors, they generally have lower blood flow. There are exceptions to that, but that can tell us that it's a lower grade tumor. So now we come to the features of the higher grade tumor. So as the tumor grows in its grading, so when it is basically a grade 2 tumor, these are the features which I showed in the previous slide. As it becomes a grade 3 and grade 4, these are the basic changes that we see. So it becomes more darker on T2, that is, it shows T2 hypointensity. It shows diffusion restriction, that is bright on DWI and dark on ADC, and it becomes more heterogeneous with features of neoangiogenesis, which I show. So look at this particular tumor. There we see this is a tumor which is hyperintense on T2, which is present in the left insular cortex, and it is involving the gangliocapsular region also on the left side. So this is an MRI at one point of time, and 3 months after this particular MRI, what we are seeing is that this region, this tumor, which was predominantly homogeneous in the first MRI, has become a little bit more darker. So what we have in mind is as the T2 hypointensity or as the darkening component increases, it becomes a more higher grade tumor. So if you look at the diffusion weighted imaging, we can see that this is becoming bright on diffusion and it is showing darker areas on ADC. So that means this is again becoming more cellular and it is showing some areas of post-contrast patchy enhancement. So enhancement, patchy post-contrast enhancement, diffusion restriction, and areas of T2 hypointensity, they signify that basically the tumor is growing in its cellularity. So this is basically a grade 3 astrocytoma. And finally, the most heterogeneous of them is this particular tumor. So we see a butterfly kind of lesion which is present in the corpus callosum genu, which is again very, very heterogeneous on T2 and flare, and there is significant these vasogenic edema or finger-like projections around it. There is significant diffusion restrictions, so bright on diffusion and dark on ADC. And these foci of blooming on SWI, they signify the neoangiogenesis and microbleeds which are present within the tumor, which again signify a higher grade. And if you look at the enhancement in this particular tumor and compare it with the previous ones, this is intense enhancement, but there are areas of necrosis, so it's a heterogeneous enhancement. It's not homogeneous, or in contradistinction to previous where there was no enhancement, there is intense enhancement, but it is necrosis with central area and central non-enhancing areas. Again, if you perform a perfusion study, which is again an advanced sequence, we can see that these red areas, they signify that this is a highly perfused tumor, or the blood flow to the tumor is quite high. So this is how radiologically also we can say that whether where the tumor is located and what is the nature of the tumor in the sense whether it's a circumscribed or diffuse. It's an IDH mutant 1p19q non-codelated tumor. And then what is the grade of the tumor depending upon how it looks on T2, what is the diffusion signal, are there any bleeds present in the tumor or not, what is the type of enhancement, and what is the diffusion restriction. So I hope that this little bit of explanation helps our residents.
Thank you, Kajri. That was very good.
Thank you so much.
To Kajri and Dr. Vani and Rakesh. You have any final comment, Rakesh? You would like to say something to students? There are still 123 students here.
No, it was a fascinating session. As much as any other student, even I learned a lot. It's always a great pleasure to listen to Vani, and Kajri, I'm very impressed with your passion. I think we should collaborate a little bit more.
Yes, absolutely. It's a pleasure to meet both of you, all of you. And it was a wonderful learning session for me. Even this is just brilliant, mind-blowing. I have no other words. Thank you so much for the invitation, and thank you, ma'am, for this wonderful presentation. It's a pleasure to be a part of this session and this panel. Thank you so much.
Comments, if I may make, for the benefit of all the budding pathologists, especially neuro. Neuro looks very complex, very rapidly changing. We are just recovering from one classification, and the other classification comes, and the NGS and molecular is just taking the breath away from you. But it is a most marvelous and fascinating branch, and I hope some of you take it up in a little bit more serious manner. But as you know, in all oncology, all medicine, pathology, you have to make very good friends with radiologists, urologists, and also the clinicians. You will not believe a child comes in our clinic, my resident has to tell what is the diagnosis. Is it looking like an ependymoma, or is it looking like a group 3 medulla, or a windpipe of medulla? So we try to, challenge ourselves, because you can tell sometimes. Even the ependymoma versus medulla, ependymoma versus pilostic low grade will be very good children. The one who is in a very bad shape is definitely a high grade. So these are some of the points which you may help when you're struggling a bit. And you don't, unlike other like breast cancer or a sarcoma, where you have tons of tissue, the margins, there is no margin, you get very small tissue. So you're totally dependent on the clinical profile as well as on the pathology, as well as on the radiology. And joint meetings, every single joint meeting and tumor board, wherever you have a chance, these days now it is online, you should not miss. What you will learn from that with the clinical follow-up is just incredible wealth of knowledge, which hopefully will help you to correct diagnosis. And as I keep on telling Sushma, our pathologists, sometimes patients come to us, cancer patients, sir, hum prarthna karte hain ki kya hoga, shall we pray? I said pray for the pathology, because pathologists are gods. They will tell you whether it is benign, malignant, grade 1, grade 2, grade 4, NGS. I cannot do anything as clinician if the pathologist is glioblastoma finished. But if she says it's a pilostic or a grade 2, the prognosis change. So pathologists actually have much more responsibility, especially in brain tumors, than actually any clinician. So with that, I thank you very much, and I wish you the very, very best for the betterment of the patients. Thanks, Sumit.
Dr. Vani, you have any final comments for students or for anyone?
I think Rakesh has said it all, and I have heard Rakesh for years and years now and learned so much from him. He's very right. We require clinicians, we require radiologists, and multidisciplinary meetings are very important. I try to make it as simple as possible so that the students could understand, and because I know that once the pathologists, particularly the young pathologists, hear the word molecular, they run away from it, and they say we don't know how to diagnose their molecular. But it's not all that difficult. You have now everything is available. All surrogate IHC markers are all available, and we have IHC surrogates for most of the molecular alterations. We don't have to fear. And let me tell you that it is good if the pathologist learns molecular pathology. Today we are all moving into that era. We may not be able to afford it in our center to perform some molecular tests, but I'll tell you that science will keep on growing and we are moving into the molecular era. And it's important that each one of you learns molecular pathology along with your histopathology and gross pathology. It is very, very important. So with that, thank you very much, Sumit, for giving me this opportunity. Thank you, Rakesh. Thank you, Kajari. It was wonderful to see Rakesh after so many, I think almost a year or so.
Yeah.
And thank you all so much.
Even I don't get to see Rakesh. So thanks to you, Vani. He came.